Okay, welcome everyone once again for the last session. I think that's actually, I'm feeling very nostalgic that we are going to, not meet every week the way we are meeting this time. So the topic of discussion today is disclosure of medical error. And I'm sure this is one topic which is usually avoided in most of the discussions. Am I right? So in your hospitals, how frequently, how comfortably are you able to, address this in an open house? If I may ask you. You can unmute and. Yes, Dr. Neha, go ahead, please.
Ma'am, normally if you say the open house, it is discussed in with few of one or two clinicians and the administrators. But definitely there is a hitch to really convey the complete messages, complete incident all throughout in the organization. There is a hitch. How the people will take it, even for the employees also. And of course, sharing, if we talk about sharing with the patient themselves, then also there is a hitch, lot of hitch. So, but definitely it is discussed in the incident committees and all among the medical superintendents, quality people, the COs, nursing level, and the main clinician involved. But beyond that, not very openly, but in the quality committees and meetings, it is disclosed in the way, yes, this incident had occurred and this is the corrective and preventive action that is being done, but is still not very open to all throughout the organization.
Thank you. What do others say? Any thoughts or any experience where actually something happened, and how did everybody react? Dr. Kundan, Dr. Manisha, whoever has some experience. Yes, please go ahead. Yeah.
Ma'am, actually, medical errors usually, if found, as Dr. Neha said, they are not openly discussed. If in case any patient's attendant comes to know, then of course there is what you say, a scandal, or they start bashing the staff that why it happened, how it can happen. But definitely in a closed committee, the RCA is done, the preventive and corrective actions are being taken. And it is only among the main clinicians or the main treating doctor, a few administrative people, and of course the CEOs and the chief of nursing, so that all the nursing staff is being told that it never happens again. They are being
Dr. Manisha, hold on. I want to ask you another question on this. So is the discussion all around how do you cover up? Of course, CAPA is one thing that we all consider that we will do. But is it any time discuss that, okay, let's talk to the family, let's tell them?
Ma'am, in few cases, it has happened that, no, it has been discussed with the family. But
because they got to know?
No, ma'am, I think it was little bit more than a little error. It was beyond that little error.
But they got to know, the family got to know, so it had to be discussed?
No, ma'am. It is the treating doctor wanted to convey to them that this is the error which has happened.
But did that harm the patient?
No, it did harm. It was what you say, it was missed.
Near miss.
Near miss.
Near miss. Okay. Yeah. Near miss. Okay. But the doctor still wanted to share?
Yeah, they wanted to share so that they are also attentive. Sometimes nurses are less and all. They just wanted to make it.
But it's a very rare case where you are saying even the near miss case, the doctor wanted to share with the patient's family, because usually near miss are never shared. It's only if the harm has happened or the family has got to know, then probably there's no escape. So one comes out, open and admits.
Ma'am, it sometimes happens that when the sisters are being told that why it happened, they discuss, and there is that nursing station and the nearby rooms are there. somebody overhears it. So it is better to avoid that they overhear the situation and then they create that misunderstanding between the doctor, the hospital, and the staff happens. So I think because of that, the treating doctor wanted and they shared it.
Okay, thank you. So I can see some messages in the chat box. I can see Sneha has written almost never. And then she's also written actively people cover except in mortality needs.
Mortality.
So only once, I mean, you have no escape, so you have to talk about it.
And
Doc-
when there is a impending loss of limb that due to some cannulation error, we feel that pulses are going down, then we do disclose because we want to save the limb. There was a mistake or some damage has happened to the vein, and most of the times we keep it cryptic, not disclosing too much.
Yeah.
But
Selectively.
Yeah.
Selective disclosure.
Yeah.
So it's a new term: selective attention, selective listening, selective forgetting, selective disclosure. Yeah, I agree. So Dr. Amrita has written, now people are more aware of their rights and are more knowledgeable. So hiding mistake is difficult. Dr. Amrit, I agree and I disagree at the same time. I agree, yes, people are very alert now, but they are very gullible. They can be fooled very easily. And I've seen that happening a lot of time, especially when they have a lot of faith in the doctor. I mean, if the doctor says in a very cordial manner that, I mean, I wanted to operate this, I saw this, I operated this also, and they are okay with this. Yeah, thank you so much that you have done this for us. And it's usually remain in the community of organizations. Yeah, Dr. Kundan, you have raised your hand. I think you wish to say something. Go ahead, please.
Yeah. So I think most of the point which are covered here, I agree with that. But medical error, I think, is a broader sense, depending upon where we practice. It is a government institute, corporate hospital, a small nursing home. Most of the time in today's 2023, I think coming out in open about a medical error to a patient, whether it has harmed the patient's life, the corrective measures are taken most of the time, maybe but inside, behind the doors, and the accountability also is set, but behind the doors. Communicate with the patient, I think it's very difficult. I have not seen openly, like, wrong catheter being placed, except few cases, like there was an instance in which in COVID era, the sister administered insulin which was prescribed for a COVID patient. For diabetic patient, they prescribed to a normal patient, non-diabetic. Those kind of error, obviously the patient also finds that there is an error. Those probably are discussed, but the patient might not be knowing, like an intensive care unit or any cannula which is going wrong or femoral. So those kind of error are difficult to for the hospital management, even how much ever ethical they are, to talk to the patient. Nowadays, patient it's for legal outcomes. Obviously, for legal and other outcomes also, medical legally also, it becomes a difficulty to be very open with the patient, at least in private or corporate setups. Also, what I feel always disclosing about error is who has committed the error, whether it's a junior doctor has committed, a nursing staff has committed, a consultant or a senior consultant has committed. So hierarchy also matters. Like if most of the time, if it's a nursing staff or a junior doctor, unfortunately, that errors are mostly discussed in even hospital meetings close. But even if a senior consultant has committed any error, so those most of the time the management will be difficult in dealing with that or disclosing to the vendor. Or sometimes the equation of the management and the consultant is strange. Then maybe that should not be taken as a to score any point over each other. So it also unfortunately happened in hospital.
They don't support the clinician.
So those, what I feel.
So if I may, Dr. Neha, 1 second, I'll come to you. I can see a message by Dr. Deepika. She says, what I have seen is if the error is very evident to the patient, then they try to be very carefully tell it to the patient. Most of the time, patient will not actually understand. Like example, using medical jargon, sometimes while disclosing, they speak more on how on how it could be solved by giving compensation terms to avoid litigation. Yeah, I agree with Dr. Deepika. I think you're right. Either we try to avoid it, or if we have to disclose, then we disclose with a lot of discretion. We don't tell everything, and we shift the focus more on how we can correct it and then also compensate the patient. I completely agree. So I'll come to both of you, Dr. Neha and Dr. Sneha. 1 second. My question is, if the patient has full knowledge of what has happened, for example, We remember that case where the patient was operated on the wrong leg, if you remember. It happened in one of the very premier institutes in Delhi. Do you remember that case? Limb was amputated.
There was one case, I think, I would not like to mention I remember that case.
So let's not mention the name of the hospital or anything.
Yeah.
Yeah. So such cases where, I mean, you can't avoid them.
Yes.
Has anybody ever dealt with situation like this?
Mm,
No.
Luckily, it never happened
Yeah.
in my theater. So
Yeah, we wish the same for
touch
everyone.
wood.
It shouldn't happen. Yeah, it should happen. So very quickly, I think Dr. Neha, you have a point to make. Go ahead. And Dr. Sneha, I think you also wanted to say something. Very briefly, what do you wish to say? Please say.
Just
And then I will go further. Yeah.
just one thing, ma'am. This many a times we would like to tell the patients so that a proper action can be in combination with the treating team can be taken and understood by the patient and patient family. But the only thing which stops us is that litigation part, and everybody is scared of that. So, I mean, these things may not be that harmful, but still, that is the one which keeps us from sharing everything with the patient and family.
You know, we don't work on building a rapport with the patient party. We don't work on winning patients' trust. So when a situation like this comes, already the patient has a feeling that we are not very, we are not very compassionate, or we are actually mainly there to treat the patient. That's all, and make money out of that. I can tell you, my friend's son. I mean, I will call him more like my nephew because they're very close to me. So he had appendicitis and he went to a government hospital because his mother knew somebody there. So they both went there, and the doctor said he needs to be operated. So they didn't want to get this surgery done. And they called, I won't again name the hospital because it wouldn't be fair for me to call the doctor's name or the hospital's name. So they called there to check if there is a bed available, and the patient, needs appendicectomy. So if you ensure that there's a bed, then we will move the patient immediately to the hospital and get it operated. So she said that once we communicated there at the reception, we received almost 10 calls from the hospital that please come, we have arranged the bed, we will immediately attend to you, the surgeon is available, doctors are available, please come. I mean, she said, she was really very, amused by the way they were calling, which is not a very regular practice, I believe. But she went with her son and they got him operated. And every senior surgeon, I know him also, but then I would name him, operated this boy. After surgery, unfortunately, when he was discharged, he came for dressing for a couple of days. He developed fistula. Now, the family didn't know what it is. They didn't know why this has happened. They wanted to meet this surgeon who had operated and who had welcomed them when they had come for surgery. Now, this gentleman didn't even come once to meet the patient or the family. Every time he sent his residents. So the dressing was done by resident for 8, 10, 15 days. I don't know how many days she had to continue going for the dressing, and ultimately it got, healed, and then everything was okay. But not even once he bothered to meet the family and even explain. It's not an error. I'm not saying it's an error. It's one of the possible complications that happen. But meeting the family and helping them understand that there's nothing wrong done by me or by anybody, but it happens sometimes and it will take some time and it will heal up. Don't worry. We will look after. I think this much of dialogue would have really sent the patient's family very satisfied and happy. Now, if we behave like this and if something goes wrong, and when we say patients, if they bash up or they create ruckus, I don't know. Not that I'm in favor of anybody, but at the same time, I think, it sends a very wrong message in the society. And I agree with Dr. Aparna. She's saying Due to such behavior, the doctor's image in society is changed. Can't blame the patient. Absolutely, I agree with you that, it's not that all doctors behave this way, but even if one behaves, wrong behavior gets communicated more than the good behavior. That's the problem. That's the problem. Okay, so I want to, give you a situation. If you remember, this case, who met with a road traffic accident, and he was admitted to one of the trauma centers. Again, I will not name the hospital. It's a real life, case that I'm sharing with you. And he was, operated for another patient on his leg. Though he didn't require any surgery or anything, but he was mistaken for another patient and he was, operated. Now the family immediately got to know that patient never had any injury on that side and why is dressing and that surgery and everything done. And now the family is asking for explanation. So anybody who is willing to take the role of the doctor who did this surgery, the reason would be that maybe the nurse misidentified or the resident misidentified, but I think all of them are equally responsible. So somebody other than Dr. Neha, because she played that role last time. So somebody who would be willing to, Dr. Sneha, you will do?
Yeah.
Okay. So Sneha is the doctor on duty. She's the surgeon who has operated the patient. And anybody who wants to act as the patient's family. Aditi, is bari aap bano, patient ke attendant. Why I'm saying, because you face a lot of it. So you will have to, gear up so that you can handle such situation. Anybody else who would like to?
दिक्कत क्या हुई है पेशेंट को?
मैं बताती हूँ, दोबारा बताती हूँ. डॉक्टर अमृत, आप बनेंगे अटेंडेंट साथ में? लेकिन थोड़ा एग्रेसिव होना पड़ेगा, because you have to show anger because you are annoyed, you are very unhappy. Somebody else?
Okay, ma'am. So Aditi and me, it's fine.
Yeah, Aditi, and you are maybe
Ma'am,
sisters to the
situation.
patient. Sisters to. I will explain the situation once again. Rather, I'll show you the slide clearly. Give me 1 second to show you this slide. Okay. So this is the case. Can you see?
It's loading.
Yeah, it's loading. And this is a real life case I'm sharing with you.
So, ma'am, I'm assuming that once the surgeon opened up, he must have
Yeah.
realized that the fracture is not there and then closed up. Right?
Yeah, yeah,
So I'll include that.
yeah.
Ma'am, age of the patient?
Around
Rough
50
idea.
years. 50 years.
Around
50.
50.
So
50.
basically, it was a open and a close surgery, but then no major procedure or extraction was done.
No.
Yeah.
Because I'm sure by the time he opened and he tried to locate where the fracture is,
Yeah.
and could not. They had the X-ray. They saw the X-ray, and according to the X-ray, they tried to locate that place where it is. But
Okay.
somehow they could not, find any fracture. So they
But how
closed
can
it.
this mistake can happen? They don't check the name of the patient before taking someone in the OT.
See, Aditi,
I
you
think-
know, what is her name? Shri Devi, you remember Shri Devi?
Yes.
Shri Devi's mother got operated on the wrong side for brain cancer, in US, not in India, in US. So errors happen because we assume that things are, going right. We don't know the patient's name. We don't sometimes confirm with the patient, the family, the diagnosis, the reports, the finding. So in eye care also, Dr. Aparna will agree with me, where there is a huge workload, like they operate, say, 100 cases a day, especially in camp-like situation. Do you think surgeons really go through the patient's case sheet? They would just be putting the patient on it's more like a, what do you call that? More like a machine they would work. The patient,
It's the duty of the OT staff, like staff resident, nursing staff,
So,
to
it
check.
is even the duty of the surgeon before operating. You have to
There
100%.
usually
There's a surgical
checklists.
safety checklist.
Yeah, there are checklists, but sometimes what happens is it becomes such a routine that just people do it, without much attention.
That is
And
where mistakes happen. That is where mistakes happen when we operate on the wrong side of the body or wrong eye. There was another case. This gentleman had to be operated for, kidney removal because he had infected kidney. I mean, beyond repair. Unfortunately, this patient's healthy kidney was removed.
Ma'am, so what is the solution for these kind of errors? Recently, I'll mention the hospital name itself in Hyderabad.
Don't
There
mention
is
the name. We don't want. Yeah.
ठीक है. So I was there in that if you permit a time, I will explain it shortly. So mother got admitted for C-section, which was planned of twin baby. I don't know what has happened. Mother started bleeding immediately after the delivery, C-section, and with minimal time she died. After her death, doctor suggested that take her to some other hospital because she is losing blood. They poor people, they took her to some other hospital. There they already told that the lady got died, and by morning we got to know that this incident has happened. So myself and few our friends, we went with some NGO people and some MLA people, some ladies of, so we went, and when we did some strike and all, then doctor after hitting him, then he got agreed, yes, this was a mistake made by us. So there was a nerve which was cut beside some, he was telling. So mother died with twin baby. They gave some, after a lot of fights, they gave some compensation. But these kind of negligence, it will damage a lot for a family, for a victim itself. So what would be the solution for these kind of things, ma'am?
So, Mamta, let me tell all of you, although, see, if you know the standard treatment protocols and the right way of doing a procedure and the surgical checklist that we are talking about, I think you will know what you need to do before, during, and after the surgery or any procedure. But if you really want to learn or understand it, I will recommend you to read a beautiful book by
Atul Gawande.
Atul Gawande. Thank you for mentioning that. Checklist Manifesto. Read that book. It will open your mind to the number of errors we all make and how you can prevent these errors. He's a neurosurgeon.
Can you just repeat the book name, ma'am?
Checklist Manifesto. I have that book with me. I think I should be able to show it to you. I have it right here in front of me. Checklist Manifesto by Atul Gawande. I think Sneha has written the name of the author. Beautiful book. Everybody in healthcare should read. Your mind and eyes will open to believing that yes, we all do a lot of errors and these errors are preventable.
So then, ma'am, in this situation which I explained, we try to reach commissioner. So we got his appointment and all.
So, Mamta, we will not go into that. Why I'm saying, because we will be going out of this.
How to handle such kind of situations? Okay. If we are counterattacking to those situations, what would be the best?
Yeah, that's what we are going to talk today. That is the topic of discussion today.
Yeah, ma'am.
Yeah, we'll be talking about that. But I wanted to open everybody's mind to the idea that first of all, believing that yes, errors happen. We all make mistakes, and most of the errors are covered. Almost, 97% of the errors are covered brushed under the carpet. They are not admitted, they are not shown, as somebody had written in the chat box, that the major emphasis is on covering up. And that is a mistake continue to happen. Nobody corrects, nobody tries to, actually make changes. Although we are saying we do kappa and everything, but that's more like a cover up, I will say.
Ma'am?
Things actually do not change drastically. Yes, Dr. Manisha, go ahead, please.
Ma'am, as you are saying that we try to cover the things and we try to give the compensation. People, when there is mortality or when there is any damage, major damage, people do take the compensations, they go away, but after a while, when they settle emotionally, they file a litigation, they file an RTI, they take out the file, they
Yeah.
find out every evidence, and then that's why these days, even when I was working recently, I saw that cases which were 5 years back are started, the people have coming and started opening them. Because somewhere in their heart, they believe that no, the doctors were not true to them or the hospital was not true to them.
You know, a recent case that has come up, it's a latest case I'm talking about, just 3 days ago. It's with my other group where we are discussing. A doctor's son met with an accident. It was a road traffic accident. It's a very grievous, incident. If you listen, you will actually be really very, sad to hear that a doctor's son met with a road traffic accident. He was brought to one of the hospitals where they, instead of focusing on treating and putting him on, treatment, and it's not me who is saying it is from the records, it is from their statements. They have been able to retrieve all that, and it is part of the case now. And rather than focusing on, saving the patient and trying whatever best can be done, they worked on actually making the family agree to donate his organs.
Oh,
And his organs were actually donated in a illegal manner.
Yeah, this is the latest case, man. Yeah, I was all this.
I read the whole case, and you wouldn't believe. I mean, I was really very disturbed listening to the whole thing. And it's a case in the court, so we can't talk about it.
Yes.
But see, there are malefied intentions in the background. So patients sometimes, when they get to realize that something wrong has been done and have been fooled, there all sorts of things can happen. But I think we are going out of the scope of the session. We have to stick to the session. The session is that how do you handle a situation when something like this happens, and you have to talk. Although law says that we have to tell even the near miss to the patient. But we know we wouldn't be doing that. But at least if we have to do, how do we go about doing? Let's see how Sneha handles this case. And Aditi and Dr. Amrit, you both be the patient's, maybe sisters, you can say.
Ma'am, can I see the patient's name again? Can you show the slide where?
It is Rakesh Tyagi. Do you want me to share the screen?
Yeah, just
Okay.
for the context.
Sure. 1 second. Yeah.
So I'll be talking to the patient himself, or?
No, not to the patient. It's the family who have immediately got to realize that, something wrong has happened, because he never had any injury on his leg. And why his leg has been, covered with dressing, and they're surprised to see the dressing on the leg.
Yeah. So I'll start, ma'am.
So I'll stop sharing. Okay.
Yeah.
So I request everyone to switch off their cameras, but just try to look at the body language and paralanguage part, and how Sneha manages the whole situation and how she handles that. Let's work on it. So 2 to 3 minutes are okay, Sneha?
Yes, ma'am.
And family should behave the way any family would behave in case if there's something like this that comes to your notice. Naturally, you will be very upset and aggressive. So you behave the way, and let's see how Sneha manages you.
Yeah. अदिति जी नमस्ते, मैं डॉक्टर स्नेहा बोल रही हूँ। मैं जो कल ऑपरेशन हुआ था।
नमस्ते स्नेहा मैम, मेरा भाई राकेश की आज सर्जरी हुई है, तो उसके लेफ्ट हाथ में दिक्कत थी, लेकिन लेफ्ट पैर में पट्टी बंधी हुई थी
जी।
मतलब हम तो आए थे एक्सीडेंट के बाद लेफ्ट की हाथ की पट्टी कराने, सूचरिंग कराने
जी,
और उसकी सर्जरी होगी लेफ्ट लेग की। ऐसे थोड़ी होता है, उसे काटा आपने, चलो ठीक है, आपने पूरी सर्जरी नहीं करी, जो भी किया आपने, लेकिन काटा उसको।
आदिति एक मिनट जरा पहले सुने तो सही, ये कहना क्या चाहते हैं? एक मिनट रुको तो सही, डॉक्टर साहब आए हैं, पहले सुने तो सही क्या कह रहे हैं, हमें भी पता चले।
मैं आपसे इसी के बारे में बात करने आई हूँ। मैं समझ सकती हूँ आप बहुत अपसेट है जो हुआ है, उसके कारण मैं पूरा रेस्पॉन्सिबिलिटी लेती हूँ जो हुआ है। आप प्लीज बैठ जाइए, हम बात करेंगे। देखिए, आई एम वेरी सॉरी कि जो हुआ है गलत हुआ है। और जो सर्जरी होना था वो आपके राकेश जी के लिए नहीं था, और एक राकेश थे उसी टाइम पे पोस्टेड, और हमने जब पूछा कि आपका नाम क्या है, हम ये करना चाहते हैं, हमारा एक चेकलिस्ट भी होता है, पर पता नहीं कैसे क्योंकि वो भी शॉक में थे शायद,
मैम चेकलिस्ट
पेशेंट
तो
भी।
होता है आपके पास, लेकिन क्या
जी
आप
जी
पेशेंट
जी,
का एज वेज चेक नहीं करते पहले, या फिर क्या
चेक
दिक्कत है
तो
उसको,
किए
किसकी
थे,
सर्जरी है
चेक
उससे
तो
चेक
किए
नहीं
थे,
करते?
चेक तो किए थे आदित्य जी, पर ये बहुत सिमिलर एज होने के कारण, और हम पेशेंट से भी पूछते हैं कि क्या आप राकेश है, और हम जब लेग क्लीन करना जा रहे थे, कोई ऑब्जेक्ट भी नहीं किए, तो हम ये नहीं सोचे कि क्योंकि हमारे साथ वो उनका केस शीट आ गया जो पहले राकेश थे, तो ये बहुत
लेकिन
अनफॉर्चुनेट है।
अगर आप ऑपरेट करने जा रहे थे डॉक्टर, तो आपने एटलीस्ट यू शुड हैव लुक फॉर सम इंजरी, कोई ब्रूज, कुछ तो
जी
आपको नजर
हाँ,
आया होगा।
जी,
हाथ में
मैं
क्रूज नजर
मानती
नहीं
हूँ
आया
कि
आपको, और पैर पे आपने सर्जरी कर दी?
नहीं नहीं, पहले का पेशेंट का वो क्लोज इंजुरी था जो बाहर नहीं दिखता है, हमारे पास एक्सरे भी था जो पहले पेशेंट का था। देखिए, मैं बिल्कुल मानती हूँ जो भी लॉजिक में बोलूं, वो आपका नुकसान तो वो जस्टिफाई नहीं करेगा।
मैम
शुक्र है कि
प्रिपरेशन भी तो होती है ना, आपने सर्जरी से पहले प्रिपेयर किया, पेशेंट का हाथ प्रिपेयर कर रहे हैं या उसका टांग
जी
प्रिपेयर कर
जी
रहे हैं, सच अ लॉन्ग
जी
प्रोसेस, तो आपको उसमें भी
जी
पता नहीं चला। और आप सिर्फ ये बताइए कि ये आपके साथ होता तो आप क्या कहते? आप हमें ये कह रहे हैं कि शांति रखें, ये करें वो करें, पर आप मुझे बताइए आपके साथ ऐसा हो जाए तो आपको कैसा लगेगा? और आप तो क्वालिफाइड हैं, आपका हॉस्पिटल इतना
जी
बढ़िया
जी
है, हमने तो
जी
कोई कॉम्प्रोमाइज नहीं किया अपने पेशेंट केयर
हम तो
में,
आपका
आपने
नाम सुन
जी।
के आए
कॉम्प्रोमाइज
थे
कर दिया।
तो देखिए, मैं मानती
ना,
हूँ
आपने
कि
किसी और को दिखा, सीधा आपके पास ही आए थे, आपका नाम सुन के आए थे कि बड़ा हॉस्पिटल है, इन
जी
डॉक्टर
जी
को दिखाओ,
अदिति जी,
बड़े
मुझे
अच्छे
बोलने
हैं।
दीजिए। मैं मानती हूँ कि आप अपसेट हैं, मैं आपको जस्टिफाई करने नहीं आई हूँ। जो हुआ गलत हुआ, मैं बिल्कुल मानती हूँ और उसका रिस्पॉन्सिबिलिटी मैं लेती हूँ। तो मैं ये ऑफर करने आई हूँ कि जो अब जो हम सूचर लगाए, उसका बिल्कुल अच्छा केयर हम लेंगे। आपके रिलेटिव का अच्छा रिकवरी होने का हम मदद करेंगे, हम पूरा ध्यान रखेंगे, और उसके साथ जो नुकसान हुआ है उसका हम कॉम्पनसेशन देना चाहते हैं।
मैम
पर
मुझे
ये
आप
जो
ये
हुआ,
बताओ, उसको जो स्टिच लगे हैं पैर पे, वो तो जिंदगी भर लगे रहेंगे ना, वो तो दिखेंगे
जी,
हमेशा। तो
इसलिए तो
एक
हम इस
डिसएडवांटेज तो है ना, जब भी वो कुछ,
जी,
अगर वो निक्कर पहने,
देखिए,
कुछ भी पहने,
मैं भी
बट
एक
नहीं भी
इंसान
पहने
हूँ,
तो
तो
भी एक निशान
कॉस्मेटिकली
मेरा
जिंदगी
ऑल्सो
भर
यू
रहेगा
मैंने
हैव,
ना उसकी बॉडी
वांटेडली
पे।
नहीं देखी अदिति जी,
मैम
मेरा भी
यू
अदिति
हैव
जी, एक
मैम
डिसफिगर्ड
मिनट,
अ
एक तो हमें
पर्सन।
अमृत जी,
अब
मेरा
तो देखो
बात भी
आपकी
सुनिए।
गलती है
मैम
आपकी,
जी,
यू
अब
हैव
आप सूचरिंग
डिसफिगर्ड
भी
अ
मैं मान रही
करोगे।
हूँ,
पर्सन।
मैं मान रही हूँ।
हाँ, यू आर
देखिए,
डिसफिगर्ड अ पर्सन
मैं मैं
बॉडी,
मान रही
दैट्स
हूँ,
ऑल्सो।
दैट इज
अब
ट्रू,
आप
दैट इज
बताओ
ट्रू।
मैम, इतना इतना किया आपने, गलती
देख,
हुई, आपकी हुई,
अदिति
आपके
जी,
स्टाफ
मैं
की हुई
मान
है,
रही
नहीं
हूँ,
पता।
मेरा गलती
अब
मैं
हम
मान रही
सूचरिंग
हूँ।
भी कराएं आपसे, अब आप
जी,
बताओ हम आप पे कैसे ट्रस्ट करें कि आप सूचरिंग भी करोगे तो
आप
सही से
आप
करोगे?
दूसरा एक डॉक्टर में भी मैं आपको असाइन करूंगी, ताकि आपको ट्रस्ट बने रहे। देखिए
मैम
आप,
डॉक्टर छोड़ो, मैं आप बताओ इस अस्पताल पे कैसे ट्रस्ट करें? लीव द डॉक्टर, हाउ वी कैन ट्रस्ट द हॉस्पिटल?
तो
Because it's not only
देखिए,
the doctor who has done the mistake, it's also the staff who has done the mistake.
जी
All are
जी
responsible for the mistake.
जी, देखिए, ये बहुत अफसोस हुआ कि ये सब हुआ है। हम एक मिनट, मुझे मेरा बात भी सुनाने दीजिए, क्योंकि मुझे भी बहुत गिल्ट है। मेरा इमोशन भी मुझे शेयर करने दीजिए। मैं भी एक इंसान हूँ, हम एक्चुअली बहुत मेटिकुलसली चेकलिस्ट रखते हैं, पर मुझे भी पूरा रात नहीं नींद आया कि ऐसा कैसे हो गया। देखिए, मैं मानती हूँ बहुत बुरा हुआ है, मैं जस्ट श्योर रहने के लिए, क्योंकि हम मल्टीपल टाइम्स देखे थे कि एक्सरे में तो है, तो इसलिए मैं मिस करना नहीं चाहती थी, इसलिए मैं खोली। फिर खोलने के
मैम
बाद
आप,
देखा
हाउ
कि
आर यू
बोन,
गोइंग टू कॉम्पनसेट? मैम
जी,
हाउ आर यू गोइंग टू
मैं पूरा
कॉम्पनसेट? यू
बोलने
जस्ट टेल
दीजिए,
मी दैट।
अमृत जी, मुझे पूरा बोलने दीजिए, आई विल
मैम
कम बैक
लेट्स
टू
कम
दैट।
टू द पॉइंट। आपके बोलने से वी आर नॉट देयर टू लिसन टू योर इमोशनल स्टोरी अबाउट इट, देयर इज नो एक्सप्लेनेशन फॉर इट, व्हाटएवर हैज हैपेंड। यू जस्ट टेल मी व्हाट इज प्रैक्टिकली बीइंग गिवन एज अ सॉल्यूशन टू अस। आप हमें वो बताइए,
तो
व्हाटएवर यू हैव डन,
सोल्यूशन ये होगा,
देयर इज नो
सोल्यूशन,
Don't
फॉरगिविंग
go
फॉर
back
दैट।
to it.
जी जी, हम लीगल काउंसलर से मिलेंगे और एक कॉम्पनसेशन पे हम अग्री करेंगे, और आप
नहीं,
मेडिकली
आप
में,
क्यों मिलेंगे लीगल काउंसलर से? हम लोगों को जाना चाहिए, दिस इज आवर राइट, हम चले
So
जाएंगे,
we'll go
हम
to
कहीं भी
media.
जा सकते हैं, हम मीडिया में
We'll
जा
go to
सकते हैं,
media
कुछ भी
and
कर सकते हैं।
tell
आप
everyone how
हमें
your
कह रही हैं कि
hospital
आप
works.
जाएंगी, जैसे कि हमने कुछ गलती कर दी, आप
हाँ,
जाएंगी, आप कैसे जाएंगे? हम
नहीं नहीं,
जाएंगे।
हम
हम
दोनों
जाएंगे।
मिलके बैठ के बात करेंगे कि क्या
नहीं नहीं,
fair
ये
है।
कोई ऐसी बात नहीं है। अभी भी आप ऐसे दिखा रही हैं जैसे हमें आपकी सुननी चाहिए। ये तो बिल्कुल गलत बात है। आप हमें क्या सुनाना चाहेंगे और क्या सुनाना, हम नहीं सुनना चाह रहे आपकी बात। यू हैव कमिटेड द मिस्टेक एंड आवर पेशेंट हैज बीन
मैं
डिसफिगर्ड
आपकी
सो मच,
गुस्सा
वी हैव
समझ
गॉन थ्रू।
सकती हूँ, मैं आपकी गुस्सा समझ सकती हूँ, पर मैं ये बोलना चाहती हूँ
मैम,
कि
आपकी
चलिए,
बातों से ये लग रहा है आप सिर्फ अपने को बचाने की कोशिश कर रही हैं। आप हमारी तरफ से सोच ही नहीं रही हैं अभी भी।
नहीं, मैं आपकी तरफ से भी सोच के कुछ फेयर, मैं चाहती हूँ कि दोनों को ये जो हुआ
There
है
cannot be a fair solution to an unfair
Because
situation,
it's
ma'am.
not our mistake. It's all mistake is
आपका
yours.
मिस्टेक नहीं है, मैं मान रही हूँ कि आपका मिस्टेक नहीं है, पर मैं अब क्या करे, आपकी क्या राय है, आप बताइए, आपकी
मैम,
क्या राय है?
हमारी राय कोई नहीं है। सबसे पहली बात तो ये है, आई वॉन्ट यू टू बी एट अ प्लेस वेयर वी आर राइट नाउ। आई थिंक उस वक्त आपके वर्ड्स भी और होंगे और आपकी बात भी करने का तरीका अलग होगा। जहां से आप बात कर रही हैं वहां सिर्फ आप अपनी बात कह रही हैं, अपने आप को बचाने की बात
छोड़ो,
कर रही
एक
हैं।
काम
यू आर,
करो,
आई एम
पुलिस को
नॉट
फोन करके
फीलिंग दैट
पुलिस
यू
को
आर
बुला देंगे, तो
एम्पैथाइजिंग
फिर
विद अस एट ऑल।
कंपनसेशन करते रहेंगे। पैसे तो एक पैसा ना देने वाले ये। लेट्स कॉल 100 नंबर एंड कॉल द पुलिस एंड कॉल द मीडिया एंड लेट देम नो कि हमारी भी से क्या, हमारे साथ क्या हुआ है। लेट एवरीवन इन द सोसाइटी नो हमारे साथ क्या हुआ है, कल से और लोग आके ऐसे सफर ना करें।
हाँ दीदी, ठीक है डॉक्टर, this is not something that can be settled like this with if you are trying to
हमने किसी और को जाके नहीं दिखाया, सीधा इनके पास आए इनका नाम सुन के। और
you are
अगर
just
इन्होंने
trying to
हमारे
pacify
बेटे
us. I am seeing that, ma'am.
देखिए,
लेट्स कॉल पुलिस एंड लेट्स कॉल मीडिया एंड
पहले
लेट देम
तो
नो
आप,
एवरीवन
नहीं
कैसे
पहले,
कैसे होता है यहाँ पे।
ठीक
मैम,
है,
इतना
पहले
बड़ा
आप
हॉस्पिटल है,
शांत
उन्होंने
होके
आपको
पहले
भेज
बस
दिया
पैसे
यहाँ पर
कमाने
हमसे बात
बैठे हैं,
करने के
पैसे
लिए।
कमा लेंगे, अब पैसे कमा के बस
आप
लोगों
बाहर
को
लोगों
चूना
से
लगाओ।
बात करेंगे, पर ये उससे आपकी क्या आपको कुछ मिलेगा तो नहीं ना? आप
हाँ
ये
मैम,
बताइए, मैं
सेटिस्फेक्शन
आपको
मिलेगा।
डायरेक्टली
वी
कैसे
विल
हेल्प
फील
करूं?
सेटिस्फाइड।
मैम,
वी
और
विल
लोग तो
फील
बच जाएंगे
सेटिस्फाइड
ना,
फ्रॉम इनसाइड।
और
बस
लोग तो बचेंगे।
अदिति बस
I am I am feeling
ये तो
super
बहुत कम
bad
बोला, हमारे
doing this
बहुत
to
बहुत बोलते
Sneha.
हैं।
I am feeling
No,
super
this is
bad doing it to Dr. Sneha. Sorry,
no,
Dr.
no.
Sneha.
I know.
ये तो नहीं, I have to tell you actually because I volunteered because I believe errors are so prevalent कि मुझे नहीं लगता कि even 10% we realize and 10% get reported. रिपोर्टेड का छोड़िए, रियलाइज भी नहीं होते बहुत सार। मैंने खुद बहुत मिस्टेक्स किए हैं जो भगवान बचा लिया दोनों को, मुझको और पेशेंट को। पर इतने सारे नियर मिसेस भी होते होंगे एंड ऑफन व्हेन वी एक्चुअली डू मोर्टालिटी मीट्स वी रियलाइज दैट दिस पेशेंट नॉट underwent not one but multiple mistakes, multiple fallacies on the medical side. तो मुझे लगता है कि ये तो प्रिपेयर होना ही है। ये I don't know how to face this. It's truly a mistake only, but the nature of it is, अब भगवान भी बनोगे और डीमन भी बनोगे, ऐसा पावर है हमारा। तो
So if I may ask you, Sneha,
हाँ,
what do you think you did well?
मैं in real life I would have been a different mess of emotions, ma'am. Frankly, I don't. It's a very scary situation. But मुझे लगता है मैंने एटलीस्ट उनका सुनने की कोशिश की instead of shouting on them and blaming them and not at least I came up to own up my mistake कि हाँ ये हुआ है and I
Right.
tried telling them my intention. Of course I don't think I was able to convey it, but in the such emotions, when the emotions are running so high, how can you convey? I don't know. So
But you
I
tried
think
your best. I think you were listening to them, you were nodding, your body language was very, kind of showing that you are, with them and trying to connect with them. You took responsibility very openly, which normally people don't take. You even apologized when you said, I'm sorry. I mean, normally people hesitate saying that I'm sorry. Your tone of voice was very good. You were being very cordial,
Composed.
respectful, very composed, very this thing. I think majorly things, went downhill when they started talking about media, police, and money.
yeah.
I'm sorry to say it was me who was instigating that.
Yes, you
But
instigated.
that is the truth. That वो तो होना ही
I
था,
wanted
ma'am.
to bring that
वो तो
up
होना
because
ही था.
that is where
मतलब मुझे ऐसा लगा कि मैं पहले मेरे मन में था कि मीडिया पुलिस लेके आऊं, लेकिन फिर मुझे लगा कि यहाँ पे पता नहीं लाना भी चाहिए कि नहीं लाना चाहिए, क्योंकि हमारे यहाँ तो हर एक
लेकिन
छोटी सी भी गलती हो
बहुत बार
तो पुलिस
पहले
का
वो
नाम
हो
आ जाता
जाता
है।
था, मैम। पहले तो वो हो जाता है, डॉक्टर
मैम,
रियलाइज होने के पहले ही।
हाँ
frankly, if that was the situation and the patient had only undergone a certain procedure, there was no amputation, no harm to the body, no loss of body part,
yeah.
then I would have actually gone with, would have been very easily, I'm not easily, but I would have been convinced by the genuineness of Dr. Sneha. She has been genuinely, I mean, I could see that she's genuinely feeling and owning up to it. And I could see that she was empathetic and that she was actually trying to, she was feeling bad about it. I think most of it, when we commit a mistake, we don't want to be seen as remorseless. We want to be seeing that remorse there. And once we see that, then I think that then we are pacified.
One message we get from your role play, Sneha, that if the doctor acts responsible and is ready to own up the mistake and apologizes and is cordial, most of the family member would calm down, especially if no harm has happened to the patient.
Very true.
They were not thinking of calling
reality,
police.
ma'am, what I see, at least in my setup, is because it is not a single provider. Often you have to carry the burden of the rest of the team's dynamics. Yeah. So often what I feel, what happens is, if there was a certain mistake, small mistake done by other people also, everything else will be doubted. And then everything else will be portrayed as a mistake. And so this is the other side of the coin.
I completely agree. So that shows that each one of us has to act very responsible. If I'm a nurse or a doctor or an attendant, whatever I am, I should know what my key responsibility areas are, and I should know what is the right way of doing my duty, so that people can't find. So that's why it's not just the doctors who need to be sensitized. Everybody should know what is the right behavior and what is not acceptable. But if everything is okay, and if the doctor's behavior is good, you can see right here that Dr. Amrit and Aditi could not be aggressive. Actually, honestly, I instigated both of them to bring about media, police, and all those things in between, because that is what I wanted.
Yes, ma'am, this is what I'm saying. She was very convincing, actually.
Very convincing.
In her demeanor, very, very convincing. Yeah. I could
And
actually have...
You softened, actually, you softened when you saw her behavior. You were quite soft when she...
Yes,
Mamta,
yes.
Mamta, you want to say something?
Yes, ma'am. So for corporate hospitals, the response will be different, and for the government hospital, the reaction would be different. Even if it is small issue, the corporate hospitals, the response will be very hectic. In government hospital, because of lack of knowledge and awareness, they may not react. And yes, Amrita ma'am.
कुछ भी हो सकता है.
Also
सीधा
depends on the...
सीधा मारने पे आ जाते हैं.
Yes, ma'am. Reaction will be very weird. You
also
can't
depends
even
on the socio-economic strata the patient belongs to. A lot depends on where the patient is coming from.
देखो, that is something not in our
अगर ये
control.
केस हमारे यहाँ हुआ होता ना, तो पेशेंट तो मारपीट पे आ जाता.
That's what I'm telling you. There can be number of factors, but what we have to focus on is that is not in our control. So what we have to focus on is if the patient is treated respectfully, addressed properly, handled properly, if his or her concerns are looked after, you will see most of the times they would respond well to such situation also if you are cordial with them.
Ma'am, does it help that, if I am the surgeon, does it help that my senior first goes and talks? He, the head of the department goes and talks that what has happened, because there'll be too much anger on me. So if they say ki, this person I have known for a long time, I know that they are genuine. I can't believe that this person could have done it intentionally. Let us sit down and review what has happened. Then the surgeon comes and then, talks. Does it help?
Definitely. See, having a senior person, as it is, actually, helps balance things, because that person would talk in a more, like we have a senior person who would talk in a very genuine way, and also, build good rapport with the family, and will be more convincing also when he or she explains. So having one or two people around you who are knowledgeable and who have good image in the eyes of the patient is definitely a good idea. But in this case, it was a patient who was brought to the hospital emergency. This was not a patient who was admitted. And actually, it was a trauma center, government trauma center, where this whole thing happened. Where we usually don't care who the patient is, who the attendant is. We just take the patient in and out, and we don't even confirm actually the details. So you can.
I have seen that checklists are there, but I've also seen that checklists are carried very, just as the people don't pay attention when they're calling out.
That's what I'm saying. If you're not following, it is as good as not following.
And like I was saying, in trauma and such patients are there already in a shock if something has happened. Usually we confirm with the patient if this is the same patient, but if they themselves are in a haze, then
Yeah.
it doesn't help. Yeah.
Okay. So we have 3 people who have raised their hand. I think Dr. Kundan, you were the first one to raise. So please go ahead.
Yeah, I think the role play was very well done. I think Dr. Sneha was great in her explaining the issue, the empathy she showed. But what I feel in such situation is, I think the assertion of the error also should be explained. Like why this error happened in first place. And it should not sound that we were grossly negligent. So there, though the technicalities like the patient rush or what happened actually, the patient identical name patients were there or whatever, so we can't justify the error, but there should be some technicalities or explanation also. And second, I think there should be a plan before disclosing to the patient. There should be a plan A, B, C about the compensation or the remedy what we are planning. Like if the patient is supportive, then what we may offer. Second, if the patient is very aggressive, not ready to listen, what remedy we have. So I think before the dialogue, if we have a remedial plan in our mind, that what are we going to offer, because see, ultimately apologizing and showing empathy is the best way, I think, because that will prevent the further things to escalate. But like in this case, like if the relatives are not absolutely listening, that what is real story in most of the cases real life, they are very aggressive, calling the police. So what remedial or what ABC plan, I think if that is prior anticipating the reaction and planning it before, I think will make it the final, because ultimately, finally, there should be a solution to this dialogue.
Agree.
Nobody, apart from empathy and apologizing, I think solution ultimately also will prevent the further escalation
That means,
of the matter.
Dr. Kundan, what you are saying, that means this should be discussed with the the management right in the beginning. If the
Yes.
loss is grievous, if the damage is grievous, if it is irreversible, then we have to have some amount or some way in our mind that this is going to be the compensation.
Yes, because if
Or if it
suppose,
is not
yeah,
grievous, then how do we handle it?
because
That
if we
means,
promise something, yeah, if we promise a doctor, treating doctors promises some X amount, and later
yeah.
on the management says that we can't pay this, and then that can be a problem, even like what I feel.
And management would not like to commit any amount right in the beginning, because then if the doctor easily agrees to that amount, they may say that you did not.
They may increase.
Yeah,
They may ask for more.
Yeah, they'll ask for more. Yeah. So Dr. Amrit, I think you want to say something. Go ahead, please. Yeah.
I mean, I just wanted to quote just a very recent incident where a friend got operated for a knee surgery and a knee replacement. और उसमें यही हुआ कि there was a blood vessel was severed and the limb went cold. But the doctor, the surgeon, who was again known to the family and to me also, so but immediately he accepted that something has happened. I mean, it was recognized and it was accepted and the patient was shifted to another hospital so the limb could be saved. So two things happened here. One thing is that the limb could be saved, further damage was saved, obviously. Secondly, the doctor was very quick to accept it, and in a way that the family was actually, they accepted, and the patient is still undergoing plastic surgery for the wound that was created in the other limb. I mean, not in the same limb also. So these are the things that could be prevented just because the doctor owned up to it and was convincing enough for the family that they could go through this torture, still not complaining. So a long way to the communication.
Again, evidence that means if you communicate effectively, you can disclose, and then family also understand that you are not God, you are human being, and you haven't committed that error willfully. But all that has to be kind of evident through various ways. I agree with you. Yes, Dr. Neha, do you wish to add something to what others are saying? Yeah.
Yes, ma'am. First thing, ma'am, almost the similar incident what Amrit had said. It was a doctor's wife who was cesareans was being done in a big private hospital, and somehow that again the wrong vessels cut and she started bleeding like hell. And but they were trying to make the compensation, and during that time they had to put the central line also because of knowing all the measures. So that was still controlled, but with the central line it was arterial puncture.
Oh my goodness.
And that was the hell. And then they were not able to just stop the bleeding. luckily the surgeons, the gynecologist husband was a cardiothoracic surgeon, and then he was called in, but he said this patient has to be shifted to the one where he was working as a government setup, big surgeon. And nobody thought of anything. They just quickly took the patient and to the RML hospital. On the way, I mean, they just were, I mean, I know the anesthetists also, they were pouring the blood simply from the, I mean, whatever getting into the drain, we'll think about the infection later on. But I'm just saying that patient was saved finally. I mean, in some way, the anesthetist also did not think anything about it, whether the infection will occur or not, blood salvage or anything. The way they just drain it was coming, and she was putting it back, somehow saved. But then at that time, I mean, of course, it was a doctor's wife, so that way the doctor knew everybody, so probably that mindset was there. They were calm that
They're trying their
kept
best.
trying, and every team was knowing that at least the patient's wife himself is a doctor and knows everybody from the same hospital. So in no way, at the back of the mind, probably they were calm in other way, that they couldn't only focus on the patient.
They did not fear any,
And that way, something. So this was one thing. And second thing is what we talk about, the errors in the OT. This is one big thing which normally occurs. The error occurs because it has to be the HOD anesthesia who makes all protocols. And I'm talking about my own experience, because it creates a lot of heartburns, because checking that list. So it is in the pre-operative room only one has to take the action, and one has to make sure that the surgical team person is also there, and then only the announcing of that pre-op part is sign-in is done, and then patient taken inside. So I have gone through a very bad phase, I must tell, because then surgeon used to be, our time is being wasted. They feel that our time is being wasted. I can see so many patients in the OPD. Why don't you first take the patient on the table, induce, then I will come. So I should say, I mean, there were used to be a lot of, I was very strict on that. And by God's great touchwood, because of this reason only, since years and years, never had any wrong patient, wrong surgery or anything. So this can be done only through when the protocols are made, that we will not take the patient inside.
We will not compromise on this.
Yeah.
Thank you for sharing that. Yeah, Dr. Sneha, you wish to add something?
Yes, ma'am. I mean, if while disclosing the error, when things start becoming very violent, and the other person is not ready to listen, so how to go about?
Wonderful. I think that's what I was thinking, that I think this part should be redone. So Aditi and Dr. Amrit, you be as rude as you were with Sneha. And this part, when you are threatening me that we are going to call police or we are going to call media, you can redo. Are you okay with that?
Dr.
Frankly,
Sneha,
ma'am,
I am saying sorry before I start. Huh?
no.
It's me. It's
Oh,
me.
ma'am, I'll tell you what. I mean, there have been instances like this, and when the other party gets violent, I frankly don't know what to do. Because I don't want to come up. I want to be empathetic, but to calm them down.
Yeah.
I think the only solution that comes to me is to have a team, so that I frankly have not been able to negotiate such things. Thank God it didn't escalate to physical violence, but I faced a lot of verbal and
Okay. So let's
damage.
quickly
Yeah.
have a role play where three of us are there now.
Yeah.
Aditi, Dr. Amrit and me and everybody. I request you to switch off your video.
So I'm not going to be the surgeon.
No need.
Yeah. Okay.
Ma'am, how can we say to you?
They think that I am Sneha. Okay.
Oh,
Mamta, can I request you to switch off your video? Dr. Sneha, Dr. Neha, yeah, thank you. So assume that I have called both of you. I have just operated and I have come out of the OT and there's a realization that a mistake has happened. And I have called both of you and you have come to my room, or maybe in the OT we have a doctor's room. So I have called you there. Is that okay for both of you? Okay.
Yes.
So I imagine that you have come in, and I know Aditi because Aditi has been with her brother. और अमृत जो है ये अभी इनके साथ आई है. I do not know अमृत जी. ठीक है? Is that okay? Okay.
Yes, yes.
So, नमस्ते अदिति, आइए अंदर आइए.
नमस्ते मैडम.
आपके साथ कौन है ये?
ये अमृत जी है, ये भी हमारी बड़ी बहन है.
अच्छा,
ये हमारी बड़ी बहन है.
नमस्कार अमृत जी, नमस्कार. मैं आपसे मिली नहीं इसलिए आपके लिए मैंने पूछा. तो अदिति और अमृत जी, मैंने आप लोगों को इसलिए बुलाया कि हमारे एंड पर कुछ ऐसा हुआ है जो मुझे आपके साथ शेयर करना है. तो आप प्लीज बैठ जाइए, मैं आपको डिटेल में सारी बात समझाना चाह रही हूँ. आपने पेशेंट को देखा, अभी मिले हैं आप उनसे?
हाँ जी मैम, मैंने देखा है.
नहीं, अभी हम नहीं मिले हैं.
मैंने देखा है.
ओके.
अभी हमें यही पता चला है कि वो जो है मेरा पेशेंट किसी के थ्रू अंदर से कोई आ रहा था, तो उन्होंने बताया कि मुझे टांग में दर्द है. अब मुझे ये समझ में नहीं आ रहा कि उसको टांग में क्यों दर्द हो रहा है. वो तो हाथ के लिए गया था अंदर.
वो उसको तो हाथ की सूचरिंग होनी थी.
अदिति, ऐसा हुआ है कि एक्चुअली एक ही नाम से हमारे पास 2 पेशेंट थे. आपके ब्रदर का नाम राकेश है, तो राकेश नाम से हमारे पास 2 पेशेंट थे. तो इंसिडेंटली जो है दूसरे पेशेंट के उनके पाँव में जो है फ्रैक्चर था और उनकी फ्रैक्चर रिपेयर होना था. बट इंसिडेंटली जो है स्टाफ ने आइडेंटिफाई करने में गलती हुई और आपके ब्रदर को ये समझ कर कि ये वो है जिनके पैर में चोट लगी हुई है, उनको हमने ऑपरेट करना शुरू करा.
मैम ये तो ब्लंडर है मैम. आप
बहुत बड़ा
इतने
ब्लंडर है
आराम
मैडम.
से हमें बता रहे हैं जैसे कि हमें कुछ
हुआ
आप
ही
ऐसे
नहीं
बता
है.
रहे हैं कि नहीं ये के बजाय हम आज ये खाएंगे. मैम इट इज नॉट डिनर ऑर्डरिंग, इट इज
This
द
is not
पर्सन्स
done,
लाइफ
ma'am.
कंसर्न्ड हियर. मैम सॉरी टू से दैट. आप जो भी है आप मतलब आप हमसे बात करने की कोशिश कर रही हैं, बट व्हाटएवर यू आर सेइंग इट इज नॉट जस्ट सिंकिंग इन.
And this is
और
not
ऐसा लग रहा है
justified.
कि आप इतने क्वालिफाइड और इतने समझदार इंसान हैं, बट जो आप कह रहे हैं दैट इज नॉट एक्चुअली बिलोंगिंग टू द पर्सनालिटी यू हैव. मुझे ऐसा लग रहा है कि आप इतने समझदार दिखने के बावजूद अपनी एक इतनी बड़ी गलती के बारे में बता रहे हैं जो किसी ऐसे इंसान से हो सकती है जैसे शायद कुछ भी नहीं आता. आई एम सॉरी टू से दैट मैम,
अमृत
बट
मैम
इट इज
देखो, हम तो
अनएक्सेप्टेबल.
आपका अस्पताल के नाम सुन के आए थे. किसी ने बोला यहाँ चले जाओ, आपको 2 बार सोचने की जरूरत नहीं पड़ेगी. बड़ा अच्छा अस्पताल है, डॉक्टर भी अच्छे, सब अच्छे. हम बस नाम सुन के आए थे. हाथ की सूचरिंग होने से पैर काट दिया आपने. और वो पैर में वो टांके लगे रहेंगे और डिसलोकेशन रहेगी, मतलब दिक्कत रहेगी, और वो दिखते रहेंगे हमेशा.
समय दे तो मैं आपको पूरी सिचुएशन एक्सप्लेन करना चाहूंगी. मैं फिर पूरी बात
कोई भी सिचुएशन को आप उसको जस्टिफाई नहीं कर सकते. राकेश सेम पेशेंट है, आई कैन अंडरस्टैंड. एज तो अलग होगी, दिक्कत पैर में तो थी नहीं, कुछ चोट तो हाथ में थी. पैर में कोई खरोच तक नहीं थी, तो आप वो कट कैसे गया पैर, मुझे भी समझ में नहीं आया.
अगर आप मुझे मौका देंगे तो मैं आप दोनों, अमृत जी आप बड़ी हैं, मैं आपको भी एक बार रिक्वेस्ट करूंगी कि थोड़ी सी पेशेंस रखें. पहले मुझे मेरी बात कहने दीजिए. मैंने आपकी बात पूरी सुनी है, मैं आपकी फीलिंग समझ रही हूँ, आपकी नाराजगी समझ रही हूँ, जायज है.
सॉरी टू से पेशेंस का तो बहुत मुश्किल है मैम, बिकॉज आई एम एक्चुअली वेरी एंग्री. और
पर अगर आप मेरी बात पूरी सुनेंगे, समझेंगे, तो हम इसके आगे बढ़ पाएंगे कि अब क्या करना है. थोड़ा सा मुझे मौका दीजिए, मैं पूरी बात आपको बताना चाहती हूँ. पहली बात तो यह है कि जो उनको ऑपरेट किया गया है उसमें उनका कोई भी अभी कुछ ऐसा नहीं कि कोई चीज नुकसान करी गई है. हमें खोलते ही पता लग गया, जैसे ही हमने चीरा लगाया हमें पता लग गया कि उनका कोई नुकसान नहीं हुआ है. कुछ भी
तो मैडम
नुकसान का तो ये है कि एक छोटे से घाव से पेशेंट मर जाता है मैम. मैम एक छोटे से घाव से पेशेंट मर जाता है. यहाँ तो सेप्टिसीमिया हो जाए हमारे पेशेंट को आपके दिए हुए घाव से, तो कौन मानने वाला है. हमने थोड़ी पेशेंट को, हमने तो ठीक करने के लिए भेजा है ना मैम. आप ये बताइए मुझे.
मैं पूरी बात
आप छोटा सा घाव कह रही हैं, हम मतलब आपको कहना नहीं चाहिए, लेकिन आप ये बताएं कि आर यू रेडी टू टेक अ लिटिल बिट ऑफ इंजरी इफ आई से कि आपको हम लगा दें और आप फिर माने नहीं. मैम देखिए ना.
आई कंप्लीटली अंडरस्टैंड आपका एंगर, आपकी नाराजगी मुझे समझ आती है, लेकिन मुझे सिर्फ 2 मिनट पूरी बात समझाने दीजिए. फिर मेरे ख्याल से मैं ज्यादा अच्छे से हम इसको डिस्कस कर पाएंगे कि आगे क्या करना है. तो पहली बात तो मैं ये बताना चाहती हूँ कि फॉर्चुनेटली हम किसी भी तरह का कोई नुकसान पेशेंट को नहीं हुआ है.
मैम देयर इज नथिंग फॉर्चुनेट इन ऑल ऑफ इट.
आई नो, आई अंडरस्टैंड, लेकिन ये मैं सोच रही थी कि ईश्वर की दया से कि कोई ऐसा नुकसान नहीं हुआ जो कि पेशेंट को एक्चुअली कोई नुकसान हुआ.
टाका लगने के बाद निशान तो रहेगा ना बॉडी पे.
वही
मैम
मैं
जो
अगर
जिंदगी
उसको
भर रहेगा
अगर उसको
निशान,
सड़क पर ही
अगर निशान को
उसको
हटा दिया तो
सड़क
उसको
पर ही
दूसरे
ज्यादा,
डॉक्टर के पास जाना पड़ेगा, निशान
मैम उससे
हटवाने के,
अगर
तो उसके पैसे भी जाएंगे हमारे।
उसको अगर सड़क पर ज्यादा चोट लगती तो शायद वो ही हम लोग अभी उससे जूझ रहे हैं, उसे भी एक्सेप्ट नहीं कर पाते। आप तो ऐसा हो गया कि जिसको बचाने के लिए दिया उसने पेशेंट को मारना शुरू कर दिया। इसकी क्या
देखिए,
एक्सप्लेनेशन है मैम, कैसे एक्सेप्ट करेंगे?
मैं वही बात आपको बताना चाहती हूँ कि जानबूझकर गलती कभी कोई नहीं करता, पर कभी कभी जब वर्कलोड ऐसा होता है और स्टाफ कई बार ऐसी गलती कर जाता है, तो मैं खुद आपसे बात करने के लिए आई और मैं खुद आपको एडमिट करने के लिए आई हूँ कि ये गलती हमसे हुई है। लेकिन मैं फिर भी ये कहना चाहती हूँ कि पेशेंट को किसी तरह का कोई नुकसान नहीं हुआ है, टांके लगे
और
हैं।
मैम एक चीज और
अल्लाह,
मुझे आप
अमृत जी,
बताइए,
अमृत
मैम
जी,
एक चीज
अल्लाह,
और बताइए।
कैन
नहीं
यू
नहीं
अलाउ
मैम
मी
एक
टू
चीज
टॉक?
और बताइए। नहीं नहीं मैम एक चीज और बताइए, आप अकेले थोड़ी इस हॉस्पिटल को चला रहे हैं, आपके हॉस्पिटल है, इतना बड़ा नाम है, आपके बहुत बड़े बड़े एडमिनिस्ट्रेटर्स होंगे, सीईओ होंगे, सीईओज होंगे, सब होंगे। वो सब कहाँ है? व्हाई हैव दे पुट यू इन द लाइन ऑफ फायर? व्हाई आर यू ओनली ओनिंग अप टू इट? आप
अमृत
बताएं
जी,
ना, सबकी गलती
सर्जरी
होगी।
मैंने करी है, सुनिए, सर्जरी क्योंकि आपके पेशेंट की मैंने करी है, तो पहली जिम्मेदारी मेरी बनती है कि मैं आकर आपसे
नहीं
बात
नहीं
करूं।
मैम,
मैम
आपको
एक
भी
काम
वो
करो,
पागल बना रहे
मैनेजमेंट
हैं
को
मैम,
बुलाओ,
उन्होंने अपने पैसे
मैनेजमेंट से बात
बचाने हैं।
करनी है हमें, वी नीड टू टॉक टू द
मैम आप उन
मैनेजमेंट।
लोगों को बुलाइए ना, मैम
आप
जो
जिससे
ज्यादा
भी
पैसे
बात
बना
करना
रहे हैं
चाहेंगे,
उन्होंने
तो
पैसे
हमारे
बचाने हैं।
वी नीड टू
एक
टॉक टू द
मिनट,
मैनेजमेंट।
मेरे ख्याल से एक एक करके बात करेंगे, क्योंकि क्या होगा अगर आप 10 चीजें एक साथ लाएंगे तो हम किसी भी एक चीज को सॉल्व नहीं कर पाएंगे। तो पहली बात मैं जो आपसे कहना चाहती हूँ वो ये है कि हमने उनको, जैसे ही हमें पता लगा उसी टाइम हम जैसे रियलाइज करा, हमने उसी टाइम उनको उस वुंड को क्लोज कर दिया, बहुत नीटली क्लोज करा है। सूचर्स, बहुत फाइन सूचर्स लगाए गए हैं, बहुत ही माइनर उस पे आएगा, वो भी पैर है जिसके ऊपर नॉर्मली जुराब वगैरह आ जाती है और कवर हो जाता है,
मैम ये
तो
तो
इतना
गलत है, आप तो, ये
मैम
तो
ये सब आप
सूजन
प्लीज
जुराब आ
हमें मत
जाती है,
बताइए।
लेकिन निशान
मैम
तो है
प्लीज
ना
आप
बॉडी
ये मत
पे,
बताइए।
चाहे पैर पे चाहे कहाँ पे, निशान तो निशान है।
मानती हूँ, मैं आपकी बात मान रही हूँ कि निशान तो है, लेकिन अगर जब कोई कोई ऐसी गलती हो जाती है तो उसके बाद में मेरे ख्याल से अगर मैं आकर आपको बता रही हूँ और एडमिट कर रही हूँ, इसके
मैम
आगे आप
स्टैंड
मुझे
ऑन आवर
बताइए।
पोजीशन, लेट अस नो कि हम कहाँ गलत है, स्टैंड ऑन आवर प्लेस।
मीडिया
हमारे
को
पेशेंट के साथ क्या
बुलाइए।
हुआ मुझे उस बेचारे को पता नहीं है, जब पता चलेगा उसके साथ क्या हुआ तो वो भी कितना शॉक पे जाएगा, मेंटल
मैम आप
हैरेसमेंट होगा
अपने
उसको।
बॉसेस को भी बुलाइए ना मैम, आपने थोड़ी कंपनसेशन देना है मैम। आपने ठीक है, आपने आप जो कह रही हैं वो हमें समझ में आ गया, बाकी सब लोग आपकी पीठ के पीछे क्यों चुप कर बैठे हुए हैं?
मैं
हाँ,
आपकी,
we need to
ऐसा
talk to
कुछ
the
नहीं है
management।
अमृत जी, ऐसा है, ऐसा कोई छुप के नहीं बैठा हुआ, ऐसा कुछ नहीं है। नॉर्मली प्रोटोकॉल ये है कि जिसने प्रोसीजर करा होता है उसकी जिम्मेदारी है कि सबसे पहले वो आकर पेशेंट की फैमिली से बात करे, इसलिए मैं आपसे बात कर रही हूँ। और अगर जरूरत पड़ेगी तो मैं उनको भी बुला सकती हूँ, कोई दिक्कत नहीं है। लेकिन सबसे पहले मैं आपको ये रिक्वेस्ट करूंगी कि एक बार आप आके पेशेंट को मिले, ताकि उनको भी थोड़ा सहारा हो, आपको भी पेशेंट को देखकर थोड़ा अच्छा लगेगा कि ठीक है, बिल्कुल कोई ऐसी बात नहीं है, घबराने वाली बात। एक
मैम
बार
कुछ नहीं अच्छा लगने
मैम
वाला,
एट द एंड तो
मैम
जो हम
कुछ नहीं अच्छा
कराने के लिए
लगने
आए थे,
वाला।
सिरिंज पे
पेशेंट,
हाथ की वो तो हुई नहीं,
नहीं वो तो
वो
करेंगे
पैरों की गई।
अदिति, वो तो करेंगे ही हम, उस वो थोड़ी वो
अब
उससे
उसके लिए भी आप करोगे, अब हम कैसे विश्वास करें, हाउ कैन वी ट्रस्ट यू नाउ कि वो सही होगा कि नहीं होगा, क्या आप लेफ्ट का वर्क करने होगा, राइट का ही कर दो।
जानबूझ के क्यों क्यों ऐसा करेगा? अब इतनी बड़ी अगर बात होगी तो और भी ज्यादा हम केयरफुली आपके पेशेंट को हैंडल करेंगे, है ना?
वो ठीक है
मैम
मैडम, लेकिन
आपके
आप
केयर पर
बताओ,
कोई
आप
विश्वास
तो
नहीं
चली
है अब
गई,
हमें।
पैसे
बहुत
हम
लोगे हमसे,
नेगेटिव,
आपके
पैरों के
मैम
सर्जरी
इट
के
इज वेरी
पैसे लोगे
डिफिकल्ट।
हमसे, हमने करवाई नहीं थी।
देखो
हम तो
बहुत
पैसे
नेगेटिव
देते
मत
रहे, आप
सोचिए।
पैसे
मैं
बताते रहो,
अदिति,
हम देते रहेंगे
अदिति
बस।
मैं आपकी नाराजगी देख समझ पा रही हूँ, और इसलिए मुझे लग रहा है कि आप बहुत घबराहट में बहुत ज्यादा बोल रही हैं, लेकिन मैं कहना ही चाहती हूँ कि एक बारी पहले
मैम
आप
नहीं,
शांत
हम इसे,
होइए।
मैम आपने जो कह दिया हमने सुन लिया। यू आर सेइंग कि आपकी गलती है, जो भी है हमने सुन लिया। लेकिन मैम आप
मीडिया
अब वी
and let
कांट क्लोज
everyone
दिस
know कि
मैटर
how
हियर।
this hospital works।
वी कांट
This
क्लोज दिस
hospital
मैटर
only
हियर।
works for money। पैसे
गो
कमाते रहो,
फर्दर,
पैसे
आज
कमाते
फॉर
रहो,
मनी,
पैसे आते
आज
रहेंगे
फॉर
हमारे
पुलिस,
पास।
आज फॉर मीडिया,
हम लोग, हाँ
ये
मैम हम
तीन
लोग
चीजों
इसका
को हमने।
एफआईआर लिखवाएंगे। हम आप एफआईआर लिखवाएंगे। पहली बात,
हाँ,
आपके हॉस्पिटल एडमिनिस्ट्रेशन का हम उसका कंप्लेंट करेंगे। एंड अगर हमें जरूरत पड़ी, इफ यू विल, पीपल विल
और
नॉट
मीडिया
लिसन
में भी
टू अस, वी विल
जाएंगे।
गो टू द मीडिया आल्सो। और ये कोई बात नहीं है, आप आपके कुछ कहने से हमें कोई फर्क नहीं पड़ रहा। इट इज अ बिग मिस्टेक, इट्स अ ब्लंडर, इट इज टोटल। हमारा आपने विश्वासघात किया। दिस
ऐसे
इज
लगा कि हम
एक्चुअली
सो
लाइक
गए
दैट।
सर्जरी में,
इट इज
पता ही
मोर
नहीं
लाइक
पेशेंट
दैट कि
को नहीं
आपने
किसी की सर्जरी
देखते
होनी
हुए,
है।
जानते बूझते हुए, इतने क्वालिफाइड होते हुए ऐसी गलती करी। तो छोटे गांव में, छोटे छोटे शहरों में जो ऑपरेशन होते हैं, सब कुछ होते हैं, तो सारी दुनिया मर जाएगी ना, क्योंकि वहां पर कौन
हाँ,
किसी को
अमृत जी,
देखने वाला है?
ऐसा है
कोई देखने वाला नहीं है वहां पे।
अदिति, एक मिनट अगर आप मेरी बात सुनना चाहें तो। देखिए, ऐसा है कि आप पुलिस में जाने की बात कह रहे हैं, मीडिया में जाने की बात कर रहे हैं, आप जाना चाहते हैं, मैं रोक नहीं सकती, आप बेशक जा सकते हैं।
हाँ मैडम जाएंगे ही, क्योंकि हमारे पेशेंट को दिक्कत हुई है,
अदिति,
हमने प्रॉब्लम सफर करी
मैं
है।
समझ, एक मिनट पहले मेरी बात, मुझे पूरी बात कहने दीजिए। आप जाना चाहते हैं, मैं रोक नहीं सकती, आप जा सकते हैं, लेकिन मैं ये सलाह दूंगी कि इस वक्त सबसे पहले हमारा फोकस होना चाहिए कि पेशेंट के इंटरेस्ट में क्या ठीक है। जैसे मैंने कहा कि मेरे हिसाब से एक बार आप पहले पेशेंट को मिलिए, थोड़ी तसल्ली आपको भी उनसे मिलकर होगी, उनको भी आपसे मिलकर तसल्ली होगी। और फिर जो पार्ट हमारा रिपेयर करना रहता है, जैसे हाथ में जहाँ चोट लगी उसमें टांके लगने हैं, उसके टांके लग लेते हैं। उसके बाद जो आप करना चाहिए आप शांति से सोच समझ कर सकते हैं।
वही तो मैं
मैम
कह
ठीक
रही
है,
हूँ
आप लेकर
आपके
चलिए
राइट में
जरा, आप
हाथ
हमें
के
दिखा
टांके
के
लगते हैं,
लाइए
राइट
मैम।
में ना लगा तो हम कैसे विश्वास करें आप पे
आदिति
कि आप
आदिति
सर्जिकल को सही
आदिति
करोगे।
रुको रुको आदिति, चलो एक बार चलकर इनके साथ पहले भैया को
आप
देख
एक
आते
बार
हैं,
देख
देखते हैं
कर
इन्होंने
चलो।
क्या, देखते हैं
पेशेंट
इन्होंने क्या कमाल किए हैं, जरा देखाएं हम भी जाकर। आई एम सो सॉरी मैम।
कैन आई रिक्वेस्ट एवरीवन टू कम इन। इन्होंने आज
सॉरी।
खाना
मैडम डॉक्टर अमृत आपके साथ कुछ ज्यादा ही हाइपर हो गई थी, इतनी तो वो डॉक्टर स्नेहा के साथ भी नहीं थी।
अरे अरे आदिति,
मेरे को
तुम्हें
तो
मैच
बोलने ही
करना
नहीं दिया
कितना
उन्होंने।
मुश्किल है।
पूरी 10 क्लासेस का हिसाब बराबर करना है आज।
मैम यू ट्रेन्ड अस वेल। So
Ma'am,
sorry, ma'am.
actually, patients don't listen when they come to know that the doctor has made a mistake.
Ma'am,
Because
it is a tug of war situation. It is more of a part tussle right now कि जो दब गया शायद उसका नुकसान हो जाएगा. So that's why also it keeps on going on and on and on.
पर वो
situation is not
sometimes you need to give break. जैसे आप उनको कहते हैं अच्छा मैं 2 मिनट पेशेंट को देख कर आ रहा हूँ या आती हूँ, तो आप थोड़ी देर निकल जाते हैं, यू गिव देम लिटिल टाइम एंड देन यू गेट बैक टू देम. आप छोड़ते नहीं है उनको, ये नहीं कि जो करना है कर लो, आई डोंट केयर, बट यू गिव देम लिटिल टाइम सो दैट दे कैन स्टार्ट थिंकिंग व्हाट नेक्स्ट एंड देन यू गेट बैक टू देम.
मैम एक बात पूछी ना, जैसे आपने बहुत अच्छे से हैंडल करा एम्पैथी के साथ हम दोनों को, हम बहुत चिल्ला रहे थे, बोलने भी नहीं दे रहे थे आपको, लेकिन ऐसे पेशेंट आते हैं, लिटरली आते हैं, जो आपको बोलने देते ही नहीं है until or unless you we raise our voices.
नहीं, उसमें
Then
assert
they start
you don't have to raise your voice, you have to actually देखो, अगर याद हो पिछली वाली क्लास तो उसमें हमने क्राइसिस मैनेजमेंट की बात करी थी कि 4 स्टेजेस होती हैं. पहला जो है एंजाइटी है, दूसरा डिफेंसिव है, तीसरा जो है व्हाट वाज थर्ड वन, किसी को याद है? चौथा तो एक्टिंग आउट, तीसरा क्या था? एग्रेसिव.
मैम एक मिनट.
हाँ, तो आप स्टेज 1, स्टेज 2, स्टेज 3 तक आप बात कर सकते हो, पेशेंट को सेटल कर सकते हो. स्टेज 4 में अगर वो वायलेंट हो जाते हैं तो आप कुछ नहीं कर सकते, दे आर इन एक्टिंग आउट फेज, वहां पे आप कुछ नहीं कर पाओगे. लेकिन स्टेज 3 तक ये है कि इफ यू असर्ट, जैसे मैंने आपको बार बार बोला कि आप 2 मिनट अपनी बात आपने कही, अब मुझे बोलने दीजिए ताकि मेरी बात मैं आपको कह पाऊँ. एंड देन यू हैव टू कॉल देम बाय नेम, एंड इफ यू नो द फैमिली. अब यहाँ पे बिकॉज इट वाज लाइक यू हैड डिसाइडेड टू आर्ग्यू विद मी, पर अगर मैंने अदिति के साथ रिलेशनशिप पहले पेयर अच्छा बनाया हुआ है ड्यूरिंग सर्जरी, बिफोर सर्जरी, तो उसमें क्या हो जाता है कि बाद में इट्स इजी टू हैंडल द फैमिली. If they know
And ma'am, Aditi would also not be that rude to you because there is a rapport already.
yeah,
We
ये
can't
तो
be that rude
इमरजेंसी
to
का
somebody we
सिचुएशन भी
know.
था.
yeah, exactly. So I saw a message Deepika has written, anxiety, defensive, acting out and tension reduction. Exactly. So जब तक वो anxiety और defensive वाली फेज में, तब तक आप बात कर सकते हैं. जब वो violent हो जाए then it goes out of your control. It completely goes out of your control. So
मेरा वो क्वेश्चन ना, वायलेंट तो होते ही नहीं, उनका पहला स्टेज ही वायलेंस का होता है हमारे यहाँ पे, कि दे जस्ट स्टार्ट शाउटिंग ओनली इन द फर्स्ट स्टेज ओनली.
अदिति, अगर पहले ही मिसकम्युनिकेशन है और उनको लग रहा है कि वी हैव चीटेड देम, वी हैव डिसीव्ड देम, वी हैव नॉट डन एनी टॉकिंग, देन दे आर लाइकली टू बिकम एग्रेसिव. क्योंकि तभी होता है कि सड़क पर किसी ने मुझे गाली दी और मैंने उसको थप्पड़ मारा, क्योंकि ना वो मुझे
कभी-कभी ऐसा होता है कि नर्सिंग स्टाफ से कोई गलती हुई है, फॉर एग्जांपल मेडिकेशन एरर, या कोई फ्रंट लाइन रिसेप्शन वालों से टीपी से कोई गलती हुई है, दे डिडंट टॉक वेल, तो वो आते हैं हमारे पास, तो हमें ये बात पता नहीं होती, वो बताते हैं हमें कि ये वो चिल्ला चिल्ला के बताते हैं. जब तक हमें सिचुएशन का ही नहीं पता ही नहीं, तो हम उसे कैसे कम्युनिकेट करें कि आप सही हो या आप, हम बताते हैं आपको.
अटेंडिंग टू कंप्लेंट्स हमने जब पढ़ा था, मैनेजिंग एंड रिजॉल्विंग कंप्लेंट्स, ये वाला जब सेशन करा था, आई डोंट नो इफ यू अटेंडेड, मेरे ख्याल से आप शायद तब आए में थे. वी डिस्कस दिस कि अगर आप अटेंड कर रहे हो, स्पेशली अगर आप हॉस्पिटल एडमिनिस्ट्रेटर और कोई आपको कंप्लेन करता है, तो पहले आप उसकी पूरी बात सुनते हो और फिर आप कहते हो कि ठीक है, लेट मी फाइंड आउट द फैक्ट, और फिर आप यू फाइंड आउट द फैक्ट्स एंड यू एडमिट हाँ गलती हुई है, एंड देन यू ट्राई टू सी हाउ यू कैन हेल्प. और उसमें आपका बहुत बड़ा रोल है. अगर आप भी उतना एग्रेसिवली रिएक्ट करोगे तब तो समझो कि झगड़ा होगा ही होगा, एग्रेसिव रिएक्शन होगा ही होगा. So your role becomes very important to calm the patient party down and also give them this feeling that you are there to listen to them and you are going to resolve the thing. पर अगर आप भी यही कहते हो नहीं नहीं आप बदतमीजी से बात करें तो मेरा स्टाफ क्या करता, आपके बाप का बात करने का तरीका गलत है, तो then that means you are refusing to take things in a very objective manner. Rather, आप already decide कर चुके हो कि patient is wrong and my staff is right. We can't
एक
behave.
क्वेश्चन और था, sometimes patient make up things, they make false accusation on the staff. ऐसा बहुत बार होता है कि रिसेप्शन पे उन्होंने इतनी गंदे से बात नहीं की होती है, गाली यहाँ नहीं दी होती, स्लैंग यूज नहीं करे होते, बट दे से कि इन्होंने करा है. एंड व्हेन वी गो एंड टॉक टू द स्टाफ, वो कहते हैं कि नहीं इन्होंने नहीं करी, और आसपास और स्टाफ जो पेशेंट होते हैं उन्होंने वो भी कहते हैं कि नहीं ये गलत नहीं है आपके स्टाफ. तो देन हुज साइड टू टेक, द पेशेंट साइड टू टेक और आवर स्टाफ
किसी
साइड टू
साइड
टेक?
नहीं लेनी और किसी को ये नहीं कहना कि आप झूठ बोल रहे हो, आप गलत बोल रहे हो. बिकॉज इफ यू विल ट्राई टू से टेल देम कि आप गलत कह रहे हो, मैंने सबसे पूछ लिया, कोई भी नहीं मान रहा, तो आप ये मान के चलो कि पेशेंट और ज्यादा आपके साथ एग्रेसिव होने वाला है. अगर वो कह रहे हैं और अगर नहीं भी हुआ, एंड इफ इट इज नॉट ए बिग डील, यू कैन एक्चुअली इग्नोर दैट. यू कैन से कि देखो हो जाता है, जब बहुत वर्कलोड होता है तो कभी कभी स्टाफ को रियलाइज नहीं होता वो कैसे बात कर रहे हैं. आई अपोलोजाइज इफ यू हैव बीन हर्ट, क्योंकि कई बार किसी ने नहीं भी कहा, उसकी कही हुई बात भी गलत लग सकती है जो उस इंटेंशन से नहीं कही है ना. दैट कैन हैपन. So I know.
Ma'am, does the number of people also is the number of people also important? Who come from the hospital side to talk to the patient?
It should never be lot of number. If you have lot of number with you, that itself shows कि it's a very big thing. So you are
over par करने की कोशिश कर रहे हो.
Yeah, overpower. You are
one,
too scared. You are too scared.
Ma'am, it could also be like this? If one person is only coming, the other party gets to overpower.
देखो अभी जैसे अभी बात कर रहे थे, आपने कहा कि मैनेजमेंट को बुलाई, तो मैंने बोला कि देखो प्रोटोकॉल ये है कि अगर गलती मुझसे हुई है या मेरी टीम से हुई तो मेरी जिम्मेदारी आपसे बात करना. लेकिन अगर जरूरत पड़ेगी तो मैं मैनेजमेंट को बुला सकती हूँ, कोई दिक्कत नहीं है, ऐसी कोई बात नहीं है. आप जाके उनसे मिल भी सकते हैं अगर आपको कोई कंप्लेंट करनी है. तो आई एम नॉट डिनाइंग बट आई एम नॉट एनकरेजिंग ऑल्सो. बट ऐसे में 4 लोगों को लेकर बैठूंगी तो उनको लगेगा बहुत बड़ी गलती है.
That's a show of power. Yeah, that's a show of power.
पावर भी, स्केयर्ड भी है, दे आर स्केयर्ड आल्सो. दोनों बातें ना. So I'm sorry, Dr. Neha and Dr. Manisha, I will have to, ask you to please hold on, because I want to share the presentation with you, a short presentation on how do you go about disclosing the medical error. And then there are 2 beautiful videos done by Indian doctors that I'm sure you would like to see. How do you go about doing it? And more than that, I think your body language, your, overall demeanor makes a lot of impact on the patient party. So let me quickly share the screen with you and take you through a couple of slides. A lot of things we have already done, so I will not, spend much time on it. Yes, Sneha has written accept emotions rather than agreeing or disagreeing with statement. Yes, I completely agree. Sneha, very right observation. So I think one thing that I want to, bring about here is when things go wrong, I think very important is the other party wants to know what has happened. So if I ask you, if you were in a flight which was in a near miss crash and some passengers including you were slightly injured, what would you like to know, and from whom and when? What do you say?
We'd like to know immediately from those who were in the flight, who were running the flight, from the pilots themselves.
Yeah. So you can well imagine, even if there is slight turbulence and you think that there was something very major, you still want to inquire what has happened. And in case if there was something very serious, I'm sure you would like to know from the pilot or from the immediate person, whoever can tell you what exactly happened. So similarly, in patient care, they get to notice if something goes wrong, they want to know. But why do we normally hesitate, disclosing the medical error? If I may ask you, what are the common concerns of the clinician?
Ma'am, backlash.
Backlash. I completely agree. I think that is one of them. And what more?
Disbelief, fear. ऐसा कैसा हो गया? First तो वो accepting it only is difficult.
Yeah, accepting is difficult.
And
is very
we catastrophize कि worst होने वाला है अब तो गया पूरा.
Catastrophize. Yeah. Dr. Neha has written about the medical legal action. Yeah, we fear that if ultimately we get caught in the trap, we can be we can be litigated. Absolutely. I think these are common concerns, and also concern about my image in the circle of my friends or colleagues, and overall, and Dr. Deepika has written loss of job. Yes, in certain cases, yeah, definitely that can also be one of the very major reasons where you feel that I can lose my job. And sometimes doctors are themselves in a shock. Yes, Dr. Neha, I agree, because if it is something that you didn't expect and that happens, then definitely you would be really shocked yourself that what exactly has happened. So disclosing of medical error is not easy because it involves a lot of embarrassment, aggressive reaction, and risk of litigation, depending upon the extent of harm, and therefore the focus is on covering the error. Yes, Dr. Manisha, disbelief, that's also there. And the medical license cancelling, yeah, in rare cases that also happens. So that fear is always there that I might lose my license forever or for a time. So actually, every seasoned doctors find it uncomfortable and distressing to communicate medical errors. This is another case where I'm sure you must have read it in news that this physiotherapist, she was admitted in a government premier institute, and unfortunately, because of delayed intervention and delayed investigation, uh, she wasn't looked after well in time, and she went into cardiac arrest and she died very young, like 50 years old, physiotherapist. In another incident, that 30 years old woman underwent a wrong procedure after complaining of minor abdominal pain. So she had come for another reason. The surgeon mistook her for another patient, made an arteriovenous shunt for dialysis, and after making the shunt, they realized, oh, they had done a mistake, and it was not the same patient. So I think these are very things happening right in front of us. Only thing is we get to know about these things when things come out. Otherwise, usually they are brushed on the carpet. So medical errors like wrong site surgery, wrong medication, wrong organ removal, wrong treatment, wrong patient, they are very, very common. Actually, lot of errors happen, in patient care. This report I had shared earlier also with you that medical errors are the third commonest cause of death in US. Almost like 250,000 patients die annually in US because of the errors. So you can well imagine what must be the state of affairs in our country. We haven't done any study, but I'm sure if we did, we will be outnumbering this number. This is another study by Ashish Jha, who estimated that 5.2 million errors happen annually in India. I would again say they're probably underestimation. There must be much more than this. Most of these errors are around medication error, patient care, and surgical error. So therefore, I think if we focus our energy on this, we can prevent these errors. And most of these errors are because of the medical errors, because of poor communication. And because somewhere, like for example, if you're not following surgical safety checklist, if you're not identifying the patient, if you're not confirming the patient, those errors are bound to happen, where patients, are mistaken for another patient. Now, by the way, what is the definition of a medical error, if I may ask you? What do you think is the definition of medical error?
A deviation from the best practices, and it is not just a complication.
Okay.
Active
Okay.
lapses.
Okay. So failure to complete an action.
Mission of
Sorry, I missed. I think somebody was saying something.
Yeah, I was saying, ma'am, even omission of some practical, I mean, some treatment which was to be done was not done is an error, or
Absolutely.
commission of an act which was not service. So omission and commission both
are medical
can
error.
be.
Yeah. So well, the definition of unanticipated outcome is when the result differs from the anticipated outcome. And the definition of omission is when something that needed to be done and is left undone, which is again a neglect of duty. Whereas patient's definition of error is very broad. For
तुम्ही
them,
ना जे काही गोष्टी कराल ना तेव्हाच्या तेव्हा लिहा. आता तुम्ही इथे 2 काय मिस्टेक केल्या, तुम्ही पेशंटचे पैसे घेतले लिहिलं नाही, जे घेऊ नका म्हणलं ते घेतले. ठीक आहे. दुसरी गोष्ट, तुम्ही जीपेचं कॅशचं तुम्ही जीपे मध्ये टाका.
Okay, so patient's definition of error is very broad actually. For them, everything and anything that has gone wrong is error. So that also includes even non-preventable events. So for example, even a complication, which is a documented complication, is considered as an error by the patient. Even the poor service quality is considered an error. Poor communication also, according to them, is an error. Whereas for physician, the definition of error is very narrow and it's only deviation from the accepted standard of care. Now, talking about the, expectation. 1 second. Yeah. Expectation of, disclosure. What do patients expect? What do patients expect? All errors, whether they are even near misses, they should be communicated. And we all know, whereas we would only prefer communicating errors that has caused significant harm to the patient. Can I request everyone to make sure that your device is on mute mode? Because in between there are, noises. So please make sure that your device is on mute mode. Okay. So according to us, I think we only think that error that has caused harm is an error. Otherwise, we normally think that can be ignored. Now, when it comes to disclosure of an error, patients prefer it to be done truthfully. They want complete information, but to be done compassionately. Whereas if you look at the physician's preference, studies suggest that they prefer doing it in a more objective manner. They would prefer minimal disclosure and also in a matter of fact manner, only to the point, and in a very, very professional manner. So sometimes being compassionate and understanding and more empathetic is something that's not really a preferred kind of a gesture. Coming to the role of apology, we all know, we normally think if we apologize, it will actually create legal liability. So we fear that if we admit, that means we will have to compensate or we will be, on the other side of the law. Whereas patients, whenever you talk to them, very often they will say that at least somebody should come and apologize that this has happened. So that is what usually patients expect. If you ask about when to have the conversations, patients prefer immediately because they want to know what has happened, what is the extent of damage, what is being done, is my patient safe, is everything okay, is it irreversible? So that's what patient wants to know in detail. Whereas we think we will do it when we have all the information, so that whatever information we provide to the patient, it should not be that something we provide and then we have to, go back on it. So therefore we avoid giving all information immediately. We prefer to be very, very sure of what we are going to share. And that also we select what we want to share and what can be avoided or how it can be modified to not appear very damaging to the patient. Now, if I may ask you, what do patients expect, by the way? Whenever there's an error, what do patients expect? Write in the chat box. Okay, I can see some answers. Acceptance of mistake, apology, transparency, honest admission of error, honest disclosure, solution, compensation, admission of mistake, apology, compensation, assurance of damage control, justice, truthful, then explanation of outcome, follow-up care, fairness and respect, acceptance of error committed with apology and proper compensation, final correction, safety of patient, what next? I think I agree with you. I think most of you have covered most of the things that the patient would want from us, and they want to know what has happened, acceptance, apology, outcome, and compensation. Yes. See, we are okay with everything else. I think compensation is something that we are not okay with. So probably if you look at it from the patient's point of view, and a lot of time we expect the patient party to pay for the corrective procedure done, or in case if the patient has to stay longer than the actual expected time of stay, we expect the patient to pay for that. So that is where the real conflict arises, because they now, of course, they have even started voicing this, but normally they wouldn't voice, but they will be unhappy that why should we pay for the second surgery or corrective surgery, or why should we pay for the longer stay that we have to do because of the mistake done by you. I think that is where they expect that should be, either done free, or they shouldn't be, asked to pay. And then last, Dr. Deepika has written also, sometimes they want to know preventive action also. Yes, they want to know what is being done to prevent this error from happening again. So patients expect statement that error occurred. They want to have the details of what happened as much as possible. They desire full disclosure of harmful errors. They want to know the implication of the error to their health, why it happened, how will reoccurrence be prevented, and then they are looking for apology and apology. So I'm sure you have covered almost everything that we have written here. So coming to the disclosure gap, 90% of the doctors support the principle of disclosure, but actually only 30% do the disclosure in a real sense. So most of us try to, kind of cover it up, avoid disclosing. Studies suggest that 2/3 of the errors are not reported. Even if disclosure happens, it never meets the patient's expectation. Trainees often do not learn how to disclose. So if you have not learned, definitely when it comes to doing it, it becomes very challenging to do it in a professional manner. You may try, but you may actually get lost in between because you don't know how to handle the aggressive reactions or the kind of questions in this role play we saw the patient party was asking. So when you don't know how to handle it, you're bound to become aggressive or show anger and temperament about it. Okay, now what are the barriers to disclosure? What actually stops us from disclosing? I saw one message by one of you that even the management would also not appreciate disclosing errors as the reputation of the hospital itself will be at stake. Yeah, that itself could be a barrier to disclosure. I completely agree. So what do you think are the barriers? Patient reaction. Yeah, how would the patient react to it? Especially if it's an aggressive patient party, then they know there will be an extreme reaction. So admitting our own fault. Uh, Sorry, I couldn't get that. There's some typing error, I think.
Ma'am, no, ma'am, my P is not working. Sorry.
Okay.
So admitting our own mistakes puts us at stake, both
Yeah,
the doctors and at
correct.
the organization.
Absolutely, I agree. So social image is a reason. Inexperience with such circumstances is a reason. Absolutely. Reputation, money, litigation, these are the reasons. Yes, I agree. And then again, fear of litigation and wrath from the management and also from the patient party. Because you never know if you admit how the patient is actually going to react. They may also become aggressive and violent with you. So a lot of, us are skeptical of the benefits and believe that disclosure is unnecessary. They think that it is not required, it's just waste of time and effort. Sometimes, they think that it is unnecessary distress to the patient and family, especially if no harm has happened, or if we have been able to take a corrective action, there is no need to inform the patient family or patient. Then, especially when they know patient is unlikely to find out, they think that there's no need to inform about the error. Of course, there's a fear of retribution from the patient and colleagues, fear of legal action and financial judgment, fear of having to handle the patient's emotions, and believe that disclosure is primarily a factual conversation and not a complex interpersonal conversation. So therefore, sometimes even when we do, disclosure of medical error, it's done in a very, very, very casual and cursory manner, and it can be very, counterproductive. And believe that the outcome is not related to the action on the part of the person disclosing. So a lot of times we say, it wasn't me who did it. Or you may also think that, since no harm has happened, so there's no point in discussing that. And then lack of training in error disclosure, that can be a barrier because if you don't know how to do it, one would always avoid. And, we have seen in a lot of, situations, surgeons would expect the anesthetist to go and do the disclosure of any error or breaking of vacuum. Even if the error is not committed by the anesthetists, we have seen a lot of times and they are made to go and, do the disclosure. But now, of course, people are asserting and they refuse to take others' responsibility. Now, what are the benefits of disclosure? What do you think? What are the benefits of disclosure? Is there any benefit? I can see some answers in the chat box. Let me go through them. Ego, yes. Losing of trust, career downhill. Will I ever be employed by others? Yes, that can be a fear. The reputation is most important. Yes, loss of trust, customers' trust at stake. Yes, I agree with you. These are common, concerns that act as a barrier to disclosing. So if we disclose, what are the benefits? Yeah, better than being known from the third party. I completely agree with this, Neha, especially your staff will invariably go and share. Staff or any of your...
The surgeon or someone else who has to do the damage control will definitely throw sand on us.
Yeah.
So it's better.
Yeah, absolutely. Yeah. So yes, trust and transparency. I agree with you, Dr. Manisha. Better and damage control can start as early as possible. Yes. The patient may finally put trust in you if already have the rapport with them. Yes, if they trust you, then they are more likely to, believe you and then also ask you to do whatever best can be done. Please do for the patient. Absolutely. So if you disclose, one, you can ensure patient safety. Whatever corrective action needs to be done, maybe a procedure, maybe transferring to another hospital, maybe calling some other doctor for intervention, whatever. You can do it quickly because if you have disclosed, then you would, take the treatment forward as early as possible. Then, of course, the ethical and legal obligation, because it's patient's right to know that if something has gone wrong, patient has right to know, and in case if we don't do, then we are also going against the law of the land. So it's a legal obligation too. And as many of you have mentioned, trust and communication will be maintained and restored if you disclose. Your patient and their family member will respect you for coming out in open and admitting. And then, of course, quality improvement, because if you let others know that this has happened, then there definitely will be, corrective action and preventive action. So automatically the quality of your, place would, work quality will improve. So very honestly, studies suggest that though we fear that there will be, litigation, actually only 3 to 5% of the patients actually sue the doctor or the hospital. Most of the patient party becomes calm after having a talk with you, after finding some way out. Either they are compensated or their care is insured or they are given some concession and some, whatever support you can give. Most of them calm. Only 3 to 5% of the patients would actually sue the hospital or the doctor. So what do patient party really want? And why do patients sue, if I may ask you? Why do
For a
patients...
feeling of injustice, they want justice.
Absolutely.
They feel exploited and they want retribution.
Yeah. So that means there is an anger. There's an anger that I have not been informed, so they feel cheated and deceived. I can see an answer by Dr. Amrit. They can win patient's trust, further damage to patient avoided by taking corrective action, and more than litigation, it's reviews these days. Yeah. So Dr. Amrit says it's because of betrayal, feel cheated. Yes, Dr. Neha, I agree. And then to avoid it to happen to others. Yes. So patients normally sue when they think that they have not been given complete information. So they decide, if I file a case, I will get access to all the information. So the most important factor, that decides for them to file a case is not negligence, but feeling that they have not been communicated properly. And when they see lack of empathy and a feeling of being mistreated, and they feel that some essential information has been withheld deliberately, and they feel that I can only get access to information if I do that. So it's not always that the thing that actually error has happened. So this one study I want to share with you. This is out of a lot of studies that I came across where they actually implemented full disclosure policy. And they found a drastic, benefit to change in the trend. For example, they implemented in 2002, August 2002, they implemented full disclosure policy, and they tried to read the three parameters. One is the annual litigation cost, then the average time to resolve the claims and lawsuits, and the number of claims and lawsuits. So their, expenditure from 3 million went down to 1 million. And the average time went down almost to 50%, from 20 months to almost like 10 months. And the number of claims also almost got to 50%, from 262 claims to 114. So in this case, actually, they, they made sure that if the patient has been harmed, they will compensate without any argument. They will compensate because the patient has been harmed before. I mean, there were three components that they focused on. If a patient was harmed, then they acknowledge and compensate those patients quickly and fairly. That is one. Second is, if they felt there was no error, they aggressively defended the case in court. And third, if there was any adverse event, they studied how to avoid them in future. So when they implemented these three things, rigorously, they could actually bring a sea change in the, in the result. And as I said, that these their cost went down, their, the time that they spent in litigation, that also went down, and also the number of cases also, got reduced, just because they implemented full disclosure policy. So a lot of studies have a similar trend and result to show, where things have really, become easier and better. So I'm going to share guidelines for disclosure of error. A lot of it we have covered in the previous 2-3 discussions. I will not be spending much time on it, but I'll make sure that the major points are focused, what we have not covered earlier. So these recommendations are based on the Canadian Patient Safety Institute and UK's National Patient Safety Agency. What they say about disclosure of error is, I think, first of all, we need to prepare. Make sure that you have all the information with you. Check, are you in that, state of mind to handle it? In case if you think you can't handle it alone, always have somebody with you whom you can trust, who can, do the in between talking and handling on your behalf. Review all the medical facts very carefully, because patient party is going to definitely ask you about that. So if you fumble anywhere, they are likely to, doubt that probably you are still hiding something and you are trying to do a cover up, So be ready for these strong emotions. As I said, patient party can become aggressive, they can become violent, they can start shouting, they may accuse you for this. So you really have to mentally be prepared that I will have to handle it. When it comes to performing, I think the first thing is begin by stating that there has been an error. So if you saw Sneha, right in the beginning, she admitted, yes, error has happened. If you try to avoid that, patient party will force you to say, galti hui hai na, error hua hai na, has there been an error? So if you say no, then they know you are again not coming out with the truth. So it's always right to start by saying that yes, there has been an error. Describe the course of event using simple and non-technical language. Don't talk too much of technical thing, they will not understand. But if you just let them happen, that this is what exactly happened, they would understand. In between, frequently pause. So if you saw Sneha and you saw me also talking to the patient party, we were hardly talking. We were letting them talk so that they can vent out. They can talk their feelings. You get to know what is on their mind. And it should always be, they should get a chance to speak and ask questions. Because if you do the monologue kind of a thing, usually which does not happen also, but at times if we think we are in authority position and we can, do all the talking and the patient party will just be listening, it can backfire sometimes. So allow the listener a chance to ask questions or clarify. And also when you are explaining, state the nature of the mistake, consequences and corrective action. So if you saw, I tried to highlight this, that no harm has happened to the patient. The moment we opened the wound, we realized that there is some mistake in identifying the patient. We have immediately closed the wound. It has been stitched very neatly with very fine sutures. So you have kind of tell them that there is a minimum damage to the patient. But of course, every situation is different. So definitely your explanation will depend on the case that you are going to talk about. This we have talked earlier also. We all know that apologizing is difficult. I know it's not easy to say, yes, I'm sorry for what has happened. But sooner you say, I think easier it will be for you to bring down their anger and start the actual action that you need to take. Try doing it in simple situations. Probably you will have more confidence doing it in actual real situation. So it also, when it is also like an expression of personal regret when you say, and then take their attention to the patient's welfare. So if you saw, I tried telling them that, see, calling police, calling media, it's your call. I can't stop you. I never said don't call, don't call. The moment if I had said don't, please don't call, don't do like this, or if I said, are you threatening me? I don't care. Go and call anybody. So it would have executed. I just put the call in their boat and said, if you want, you can do that. But I think right now we should focus on how can we, minimize the damage and see what can be done best in the patient's interest. So apology, as I said earlier, also is more of an expression of compassion, especially if the error hasn't harmed the patient party. But of course, taking responsibility if something has happened, and even not only harm the patient, like for example, in this case, not a serious harm has happened to the patient party, but you could see how aggressive they were. So taking responsibility that yes, this has happened, and we failed in identifying the patient in a way that communicates that we are owning our mistake. Sometimes when we accept but we don't accept, then apology fails. So if I say, yeah, there was an error, but see, your patient has not been harmed. Nothing has happened. It's just a couple of sutures. It will heal in few days. It's not a big deal. So if now Aditi said the sutures will be visible and it will, look odd. I mean, had I been in an argumentative mood, I would have said the other sutures that the patient has attained because of the injury, will they not be visible? But no point making such kind of an argument. So when you apologize like this, there was a mistake, but it was a minor thing. I think you can overlook. Or yeah, mistake certainly did not change the outcome. And in any case, this had to happen. For example, if it is a wrong side surgery for eye, for example, or for example, the patient was unlikely to regain vision, and you say, in any case, vision to aana hi nahi tha. I mean, the vision wasn't up. I don't think that kind of apology helps. And then when you say sometimes these things happen, but that they are not done deliberately, these are not the ways that we apologize. So take responsibility, use I statement as often as you can. Don't blame or speculate. Don't blame the family. Don't blame your staff. Don't accept fault unnecessarily. If you haven't done anything, wrong deliberately, if you will accept it, I'm sorry, they're likely to kind of, become more powerful in that equation. So invite questions when you ask them, what questions do you have about it? But that will only happen once they calm down. For example, in this case where Aditi and Dr. Amrit were, in the patient party's role, they were just not in mood to listen or talk. So probably here my asking what questions and concern you have would not help. But sometimes when the patient party starts calming down, that is where you can say, I know this has happened and we are going to do this. Do you have any concerns about it? Do you have any questions about it? So that is where when they ask you questions that, what is the damage? Is there will be any problem in his walking? Will he be able to walk the way he walked? Or will there be, how much time is it going to take to heal? Or there could be financial concerns. So who will bear the cost of the stay in the hospital? So these concerns need to be addressed, appropriately. And for that, you need to invite questions. So with the patient party, it's important to make a follow plan, what you're going to do, or how you're going to minimize the damage. For example, if you're going for a second surgery, then you say, we are going to operate immediately and, correct the error. Or whatever kappa you have planned off, you can even talk about that. How you're going to meet the needs of the patient and the family. They may say that we have come from a far off place and we don't have, anywhere to live, for example. So how can you help them, with those things? Even that also kind of calms them down. Plan for the next update. For example, you have put the patient in the ICU. Now the patient want to know, when will you tell us what is the status? So how are you going to update them? And then very important here is remain accessible. I mean, in such cases, even if you give your phone number to them and tell them that in case if you have something to ask you and talk to me directly, there is nothing wrong, there's no harm. Getting anybody's phone number is just 1 minute job. 1 minute job. So don't think that if you don't share your number, they will not be able to get it. So, but creating that cordial conversation is very important. And when you offer them that in case if you have any question, you can call, message me, I will reply to you as soon as I get time. Then after you have done this talking and you've kind of settled them down, it's important to document, because I think every incident that happens should be documented to learn from what happened. So report the incident and actions taken by you, rationale for the clinical decision. For example, whatever clinical decision you took after the incident, make sure to note that down and the reason why you took that decision. Then the clinical outcome of your decisions and further plan of care. Discussion with the patient and family, what you informed, how you informed, what was their reaction, how did they take it, all that has to be documented. So the name and the relationship of those people who were present in the discussion, questions they asked and the answers you gave, all that should be part of the documentation. After the situation is over, I think reflecting is the best way to prepare yourself for a second situation. So very important, sit back and check in yourself. How are you feeling? How did you feel in this situation? What you think you did right? What you think was not appropriate? So just revisit the incident and try to see how could have I done it differently or in a better way. Discuss with your colleagues, trusted colleagues, and then ask them how do they handle or how differently would they have handled it. So that's a good way of learning from each other when you share your situation and cases. Read material to update yourself. Lot of material is available on Google. Lot of studies are available that support how to do and what to do and what not to do. And then, of course, attend programs to learn crisis management and handling difficult conversations. So these are few ways you prepare yourself. But just not talking about it is not the way out. I think as a system, we need to prepare ourselves. So to summarize, I would say that it's important to, first of all, prepare yourself when you're going to do it. State what happened simply, offer apology, take responsibility, invite questions, answer their concerns, make a follow plan, and then document and reflect with yourself. At the institutional level, I think we need to make sure that we integrate disclosure, patient safety, and risk management activities in the training part. So we really need to talk about it so that people become comfortable that errors can happen. And one point that I haven't mentioned anywhere, I was hoping that somebody from you would bring in, and that is the concept of second victim. I think a lot of discussion now is going around to see that the person who actually has to face the consequences of their action or error, they actually suffer a lot of anxiety and other mental health and emotional concerns. So they're more like second victims. So management and peer group should come forward and support them and also make it easier for them to come to terms with the reality. So establishing a disclosure support system in this system will give support to the person who has to face the music. So providing background disclosure education, for example, we have talked in this session, if you talk in the same manner with your team in the hospital, I'm sure at least some discussion will begin, some interaction will begin, some opening will be made, where people will start realizing, see, whether you like it or not, but there can be a point where you need to talk about it. So why not, talk about it and discuss and become more comfortable with the idea. So ensure disclosure coaching is done time to time. You can like we did this role play. I mean, if you do this role play maybe a couple of times, slowly people will become comfortable with emotions, with words, with the solutions, with their demeanor. I mean, they'll get feedback from each other. Okay, I think your tone of voice was very good. I mean, but your facial expressions appeared little aggressive. So you need to really, tone them down. So that's how we can work on each other. So that means we require this to be done in a very meticulous manner. So provide emotional support for healthcare workers. Like I said, people who go through this, they also experience a lot of setback. Create a culture of patient safety where people report errors, in an honest manner. Rather, they are rewarded for reporting. Rather than being punished, they are rewarded. So a lot of errors actually can be prevented if you create a culture of reporting the error. And if you don't punish the person who comes up with the report and you rather reward the person, automatically, I think we'll be able to, continuously bring quality and improve the quality implementation. Create a culture of employee safety. Again, anybody who has done a mistake should not be targeted or punished or reprimanded. Rather, how can you empower that person with the right skill, right understanding, right knowledge, so that they actually practice patient and employee safety. This I talked about. Create a culture where people report errors promptly without any fear of repercussion, and then use performance improvement tools to track and enhance disclosure. So when people are doing the disclosure, it can be done under CCTV. Others can, observe, and then later on they can discuss how that person did, how differently that person could have done it, just to learn from what we have done. I can see a couple of messages in the chat box. I think disclosure can happen when there's a culture of acceptance and kindness among staff rather than politics and hierarchy. Absolutely, I agree, Sneha. I would say, see, you can't dictate others to do it, but when you express, when you show that gesture, I think that makes a big ring in the bringing change in the culture. Suing is an attempt to stop such, what is it? 1 second. Is an
And that
attempt.
was for the previous question, ki why people sue.
Yeah. And this to health of a patient is extreme. So what I'm trying to say, there has to be a whole culture of where people become more, patient centric. Patient safety, employee safety is, desired, respected, and practiced. And then also we create a culture where people come up and promptly report if there is any error. So this is in nutshell about disclosure of medical error. I know it's easy said than done, and there will be challenges when you will try doing it, but closing our eyes to this is not the way out. I think that's what is my learning. The more you will talk about it, more comfortable we will become with the idea of, talking to the patient, and also bringing to the knowledge of people that if you make error, you will have to face the music. So be more careful and practice patient-centric care. Any questions about it? We have had a huge discussion about it. A lot of things came up. Dr. Priya, anything from your side?
It's still scary, ma'am. Like,
Sorry?
Again,
still it is scary.
very scary. Very, very difficult situation to handle is what I think.
So honestly,
Ma'am, one idea, like how we display patient rights and responsibilities, can we also have some display ki, we have systems in place, but so and so things do happen. I think only when patients also understand that we are not gods, that we are also humans, some kindness on their part. If we are assured of kindness on their part, I think
I
it's
think
easier
what
to
I have seen in number of cases, I can give you lot of cases. I have seen if your overall conduct with the patient is cordial, right from the beginning. If they ask some questions, you sit and answer, you explain them, you give them chance to speak, you consider their concerns and you address them appropriately. Mostly the family is okay with whatever the outcome is. That's their opportunity to take revenge from us. Because all the while we have kind of, given a very cold kind of a behavior. When we don't want to build any connection with them, when we don't want to talk to them nicely, when we don't want to address their concern, they tolerate it, hoping for the patient's recovery. But in between, if something of this sort happens, then they don't forget. I remember 2-3 cases that I can quickly share with you. One, I think I shared with you about a resident. I took a session for a group of gynecologists, so who delivered a schizophrenic mother. Did I share that with you?
Yeah.
So this
Antipsychotic
resident,
medication.
yeah, that resident said with everybody, the patient's husband misbehaved, fought, and also broke things. He said with me, he did not misbehave. He did not say a word. Just because she had developed good rapport with the patient. We are underestimating the power of building a rapport. I have a lot of faith in it. I've seen people suddenly calming down when they see somebody who is familiar to them or with whom they have, that kind of a belief that this person is a nice person. I remember at AIMS, Rishikesh, I had gone to take a program, and Dr. KPS Malik, who is retired head of the department from Safdarjung Hospital, is a consultant there. So he shared his experience that a lot of time patients lose their eyesight after surgery due to any reason it could be. And in spite of that, they would come and say thank you to him. He said patient would come and say thank you, not for the loss of vision, but saying that you did your best to help me or save my vision. Though I lost my vision, that's my bad luck, but I can't say that you have failed in doing your duty. I think that message is very important and we really need to value that.
Such patients are saint. जो ऐसा कहते हैं वो, एंड मैंने तो ऐसा कोई पेशेंट नहीं सुना जो ऐसा बोलेगी थैंक यू, आपने अपना काम करा.
Ma'am, one more thing is there that we don't pay attention to this. We lose on a lot of rapport building time because we are not preparing ourselves for any eventuality. We just think it is going to go all fine. So we have actually missed on that time. Every moment is important of your interaction with the patient because you don't know what you said or what you did is going to become your shield later on. So from the beginning, we have to be very aware of anything can go wrong because it concerns with somebody's health. So we can never be that, we can never be so relaxed about it. So shuru se every opportunity should be taken up. This is what you have reinforced. This is what I have taken it. ये वो बहुत important है.
Absolutely. So I can see an answer by Dr. Kundan. He has written, sadly, in today's world, when governments don't own mistakes, when judiciary never apologizes for a wrong judgment, where corporates never accept about wrong products, engineers never apologize for a crash bridge, onus is always in healthcare professionals reflecting medical errors. Only torch bearer in a difficult world. So, Dr. Kundan, I appreciate the write-up that you have written, but my concern is about the healthcare professional who is alone caught in this situation. He is the one who will have to face the music, be it physical violence against him or her, or legal action. So, personally, I feel each one of us should communicate effectively, behave well with the patient party. Of course, for the patient, but for our own safety also. So if you are able to at least keep that in mind, that I remember, as I said, I take sessions at MAMC. I would not name the professor because it will not be fair on my part to name anybody. He would often say that he has a colleague who is an average surgeon, and lot of time his surgeries are botched. But patients still are happy with him because he knows how to win patients. And we have seen this happening. So there is a power in building good rapport because patients also, I don't want to use the word emotional fool, but then they get fooled because of emotions.
Ma'am, because you have a lot of experience of, you have interacted with a lot of people and you have been in here for a long time. So do you think this corporate hospital thing has made it worse because they are being looked at as business houses minting money by the patients? Because I don't think it was that much in earlier times when only government hospitals used to be there in numbers and the private practitioners used to be there. I think it has become more prevalent now.
There
Far
are
more.
many factors. There are many factors. One, patients, nobody will have spare money in the bank for medical care. Usually they are paying through nose when they pay for, especially if they don't have any medical cover. So when somebody is paying so heavily, and then ultimately the patient outcome is not as expected, and over and above that there's an error. So it's like, since we had not prepared them for that, and if there's an error, they are likely to get aggressive. And in general, I think aggression is on the rise. Other than that, I think overall, you see an environment around us, culture around us, perception of medicine. This has really gone down, which was never like this. So there are multiple factors. But I would still say individually, each one of us should be careful in our own role. If you can, maintain your good image, work very responsibly, follow the protocols, you will be able to minimize errors. So if you remember that Swiss cheese model of error, there are so many checkpoints. Error happened when every checkpoint was missed. So in surgical safety checklist, making sure the patient is the right one, it's not just the doctor's or the surgeon's responsibility. There are so many people in between who has to make sure that it's the right patient going for the right surgery to the right doctor. That means everybody missed. That means nobody is acting responsible. I would recommend read that book on Checklist Manifesto. Your whole way of functioning will change. Okay, we have, how many presentations do we have today?
I have mine.
Okay, Sneha. Who else is left, by the way? Only Sneha?
No, ma'am.
Who else? Dr. Manisha, 1 second, I'll come to you. I just want to make sure that everybody has done the presentation. Everybody has done the presentation? Who else is left? Dr. Aparna. Dr. Aparna, are you there? Who else is left? Santoshi, have you done?
Yes, ma'am.
You have written yes, ma'am. I thought maybe I missed on
No, no, all done. Those who are there in the call, they all are done, ma'am.
Okay.
Dr. Sneha and Aparna, ma'am, is, I think, left.
left.
Rest all of us done.
Okay, I think Dr. Manisha, you wish to add something?
Yeah, ma'am. So regarding, as you said, that at every point there was a miss. That's why the error happened. Of course, we all working in the hospitals know that when a patient gets admitted, it has a unique identification number. And along with the patient's name and the unique identification number, at every point it has to be checked. And before the surgeon operates, there are terms called like wheel in, check-in, sight. They repeat it before the surgeon takes the knife on the skin. Again, the sister in charge of the OT repeats it. That patient's name, site of surgery, name of surgery, time taken for the surgery, any complication, any special instrument required, everything is being asked. So if it is not asked, that means not only the surgeon, the other staffs who were there in the OT or the OT technician, nobody took care of it.
Absolutely. Absolutely. That's what I'm saying. It's not one person who goes wrong. It is the whole system that goes wrong when errors happen. Thank you for bringing that up.
And
yes.
Also, ma'am, that whenever any surgery is planned, both the complications of the surgeries are being explained.
Mhm.
So if there is a complication, the patient is being informed by the operating surgeon, but if there is an error, that is also to be informed.
Absolutely. Absolutely. Thank you. Yeah, Sneha, can we have your presentation?
Yes, ma'am.
Yeah.
Just a minute. I'm sharing my screen.
Okay.
Hello, everyone. We'll start off with can you see my screen?
Yeah, but it's still loading, I think. It's
Okay.
black actually.
Acha. Now?
Yeah. We can see that you have started sharing your screen, but we can't see anything.
Okay. Till that time, because I'm just going to start with a scenario, I would request everyone, I know it's pretty late, but please participate because this is the last session of our journey together. So my session is about Socratic questioning. But first, I would give you a case in a scenario wherein we are all administrators and staff on a hospital board, and we have called a meeting, and I am asking each of you who are doctors and administrators for your inputs regarding a situation that has arisen. Now the situation is that the report shows that there is falling income, falling footfall in the last 3 months, and overall our ratings are also going down. So I start off saying, giving the report to everyone, and I invite your possible explanations and your viewpoints. Can any one of you volunteer? This would be a group discussion, but each of you can volunteer some possible points. So why do you think our revenue is falling? Is the Yeah, can anyone volunteer?
Yes, I think I can. May I?
Yeah, please, ma'am.
Yeah. So we have to look into the how we are treating our patients. What are our incidents forming? What are our waiting times in the OPDs? What are our waiting times for the operations? Or whatever waiting times in the ward for the medication administration or starting the treatments? Any incidents happen? Any falls? Any medical errors? And how are we dealing with them? So these are the main things we'll have to look into how we are going about this. As soon as the patient enters, starting from that point, how are we doing the patient and family educations? How
Yes,
we
ma'am.
making them comfortable in the ward? So all those
Yeah,
things
true.
will make the effect.
Wonderful, ma'am. Can anyone talk about how we can assess especially when ma'am said waiting time in the OPD, because OPD seems to be one problematic area. Can someone come up with an idea of how to assess the waiting times?
Prior
We
appointments.
So, is there any other? Can someone tell what has changed in the last 3 months that this has happened, which was not there earlier?
If I could add on a reason on why the income
Yeah,
and
let us imagine if something is happening. You can just come up with that imagined situation.
yeah, so if I could add on what are the other reasons, possible reasons on why the income and the patient footfall is coming down is could be because there is a new corporate hospital, a well-reputed hospital, a strong competitor of us who is come up in this particular suburb, and that's one of the major reason because till now we were the only center, so the patient footfall was really good. But for the last 3 months, we are seeing the dip mainly because the other corporate hospital who is well reputed in the market has come up.
Thank you for your viewpoint. Yeah, that's a new viewpoint. Anyone, do they think that this? Does anyone else have a different assumption or a different viewpoint?
Yeah. Can I say something?
Yes, ma'am.
Yeah.
Everyone is welcome to join in.
Yeah,
Yeah.
it is. It can be like whosoever the consultants we had, maybe because of some reason, some of the consultants have left. And that's why when the patients come, sometimes the patient come for a particular consultant and they have
So-
already left for some reason. So they
We
will
are
not be
assuming,
coming.
ma'am, just to break in, we are assuming that this is because of competition, but is there another viewpoint that maybe it is our own processes that have been falling in the last couple of months? Maybe this other corporate
Yeah,
hospital is
this
just
can be, it can
This
be
can
another
be,
processes like we, let's say, scheduling of OTs. When we say about the consultants, they don't schedule their OPD timing and the surgical timing, so again the waiting time comes here. So they
Yeah.
maybe they've started putting the cases on all days, the consultants, and haphazardly, and so
True.
patients are just coming and waiting, and they are not meeting the consultants.
True.
They will
See,
be
that because sorry to cut you off, ma'am, but I'm just cutting off because there's a shortage of time. Like I was saying, it is not just that our footfall has decreased, our ratings are also decreasing. So I'm assuming that something is going wrong in our own quality. And like ma'am said, our OT waiting times are increasing, our OPD waiting times are increasing. So
Dr. Sneha,
yes,
newer
ma'am.
advanced treatment modalities need to be incorporated.
Yes, ma'am. That's true. So
I
can
mean,
we?
yeah,
I would say, but can we? Do we have evidence to say that that is going to be cost effective at this point, rather than improving our methods, our quality, our processes? Because earlier, even without these advanced modalities, within a short span of 3 months, our footfall has and our ratings have decreased. So I'm assuming that something has happened acutely.
maybe our infection rates
Attitude.
increasing.
I think then it has to do something with the attitude of the people, maybe the way they are communicating and handling the patient.
That is true. That is true.
maybe we lost our senior consultant. That could also be the reason of patients having less numbers. And
So,
also the
because
marketing, maybe we need to increase our marketing to be a equal
when
complement to other.
when our existing customers are giving us poor ratings, I think it is better to focus on improving our quality, rather than putting our efforts in bringing more patients and giving them poor quality. So I think yeah.
maybe Dr. Sneha, the patients, the doctors are not patient centric.
Yeah. So that is possible. Is there any other explanation that could be happening in because it has been happening in such a short while?
Maybe the
Can we
infection rates.
explain a single, because I've been saying that it has happened over 2-3 months only. Can we come up with a single explanation, a single point of change that, has caused such a big problem?
Maybe bad Google
Then-
reviews.
That is also possible. Yeah, that's one
I
thing
think
we should explore.
we should connect with our consultants and have to know them whether there is any gap between the mission of the management and the consultant. So
Yeah,
we should
Yes.
try
that
to
is
know
true.
whether they are any unhappy over some policies of the hospital or something. I think that also needs to be learned.
Or
Yeah, that
maybe
is
Any
We
change
can
in
ask the
protocols in
patients
the
also.
or
hospital?
maybe
okay.
We
maybe
can ask some old patients also if they are finding any problem, any change in the hospital administration and at other levels.
Yeah, that's a wonderful
And look
idea.
at the feedbacks more seriously.
Yeah, wonderful idea. So to
Protocols
summarize,
of the
I would be,
hospital, Dr.
because
Sneha.
because this is just a first brainstorming. I think we would collect ideas. I'm just summarizing. Moving forward, we'll take these actions. First, we will check into. We will talk to our patients and find out what exactly is going wrong. We'll check our Google reviews, keep what the patients are specifically writing, and then we'll check our compare our previous OPD timings and OT timings and check our timings right now. So
one
I
more
think I
thing
mean,
is cost.
moving,
Probably the schedule of charges were increased.
yeah, that is also possible. Yeah, true. So moving forward, I think I am not sure I did a good job, but yeah, my topic is actually Socratic questioning, but it more converted into a brainstorming session. But they're very close. There are some similarities. So Socratic questioning arise. This is a pedagogy where we bring out information and knowledge, and we try to teach the people in front of us. Rather than telling them what is wrong, we ask them questions so that they introspect and come up with possible solutions. So this comes from a philosophy of Socrates. Is my screen visible? Is my PPT visible?
No.
Dr. Sneha.
No.
Oh,
Not visible.
oh, okay, just a minute. Let me fix this. So I actually intended this to be a session where I'm trying to give a feedback and a request my doctors to look into their own practices by asking questions. Just a minute. Let me see what's wrong with this screen sharing. I'm able to screen.
It is saying that it has started screen sharing, but
Acha.
yeah, but
Just a minute,
back.
ma'am. Let me see what's happening. I'll stop share and reshare.
Yeah, maybe it's hang.
Yeah, just a minute. I'll just share one document. Maybe that'll help. Yeah. Is this okay?
Yeah, now we can see.
No, ma'am. This is the wrong document. Just a minute.
Okay.
I'm so sorry. I thought this is sorted, but I didn't think it'll be a problem. Can anyone help me? Anything which I can do? I'm sharing my screen and.
Dr. Sneha, you can send your PPT to ma'am. Ma'am will share from her.
Okay, I'll do that. Ma'am, is this visible now? If not,
No,
I'll do that.
black. Yeah.
Is it visible now?
No.
Acha. Okay. Ma'am, can you? I didn't make much of changes, ma'am. Can you start sharing, ma'am?
The same
Do
way.
you? Yeah, same. Because the earlier two, which I added, we anyway discussed in as the case scenario.
Give me a second. Yeah. Let me.
So in order to just save time, I'll just go ahead with the talk. Socrates always believed that you cannot actually teach someone and change their behavior and make them learn something. He strongly believed that you can only make them think. So that is why the school of thought of and this pedagogy is named after him. And most of his teachings, which are written by Plato, all are in form of dialogue. So he would just gather people and start asking questions and examine their beliefs and build upon their arguments. So what is the method? So when you're going to teach a session, what we do is we have pupils with either or our colleagues with either a common shared experience, or you have provided them with a text or some movie they have seen which is common for all of them, and then the teacher does not start discussing about it but asks questions. These questions are directed, they're well thought about, and they're intended to probe and bring out their thoughts. They are intent on exploring the values, the ideas, and the concepts and the reasoning of the pupils. So it all has to do with higher order functioning of, higher order mental functions rather than just knowledge. And we need to wait for the answer. Oftentimes, when we ask questions, especially those which challenge their assumptions, which challenge their belief systems, we need to give them this time to come up with a framework which is able to answer your question. If you pressurize them to answer too quick, then your purpose will not be solved. And then once they give you an answer, build upon those points in order to sort of uncover more truth, bring out more and more possibilities, and engage as many people as possible, and then make sure that you summarize, because ultimately we want an ending and a learning, a takeaway key point from the entire thing. So what are the benefits of using this method of teaching? It is it has better engagement, and it is especially, like I said, it is especially useful when you want to challenge beliefs, and you want to encourage higher order analytical thinking, and you want to change behaviors. So like this is very much what ma'am has been using in our training. She has not been telling us what to do, but then she's giving us situations and is making us think. This sort of helps us as adult learners to be more open-minded and actually analyze our own experiences and learn from our own experiences. So what happens is when a person has many experiences, but then once they verbalize it in the context of a certain question, they are able to come up with answers on their own, and they are able to learn better, and they're able to retain this knowledge better. Also, because adult learners are learning from their peers who they think as equals, they are more likely to engage and remember what is being taught. So the benefits as compared to a didactic teaching is that, like I said, better engagement. You have better, it is better suited for tasks which need someone to go and function, to go and analyze at that moment, because communication is something which is a very high order thinking. The person has to be very present, needs to be very empathetic, and also know what to say and imagine ahead what the consequence of this particular statement which he's going to say is. So for such high order skill, this is a better engagement tool. And then, because we need, this is so much in tune with values and principles and beliefs, rather than didactic teaching, when you ask questions, you are giving scope for your students to explore their true values. Because we may say that the ideal value is empathy, the ideal value is to put patient in the first, but then if you don't give the space and time to the person in front of you whom you want to influence to actually explore their true values, and then accept their values, and then find a way how to incorporate these ideal values over their existing belief system, things will not change. When in stress, like ma'am said, this is what we will resort to our baseline values. And therefore, if you just tell people what to do, it is not going to translate into action. And then Socratic questioning, this pedagogy focuses on perspectives and behavior rather than just knowledge transfer, and it helps question beliefs and clarify thought. So what are the basic tenets? Like I said, the teacher is supposed to be an active participant and should be open-minded to learn from the pupil. Oftentimes when we go to teach and train, we don't know the ground reality of the true difficulties that are happening, the staff is facing, which are the true barriers for change to happen. Once you go to them and talk to them and question them, and you're open to listen, then you understand the full picture, and you can come up with solutions to the existing problems. And then the teacher during the session should not be very should not look for difference. That means should not be looking for respect, but should create a culture of mutual respect. And the aim of the session is to create intellectual discomfort. That means you're challenging the person's values, and you are also challenging ki this is the ideal value, and you yourself know that this is the ideal value, but these are your existing values. And you're giving them this cognitive the discomfort of knowing that these both are different, and you're showing them this is also important when you're challenging their perspectives and their reasoning, because oftentimes we carry wrong reasonings with us. For example, if I say, I can't change the system because it's just too complicated, that is true for me, but then you're when you present an alternative perspective, when you ask this question, but how is, when you ask a question key, okay, what you're saying is fine, but how is this going to benefit anyone? then the person is going to think of another beneficial way of thinking. And you're not intimidating them, you're not criticizing their way of thought, but you're showing them a different perspective. And we need to agree that we need not have all the answers for this complicated situation, but then we are facilitating thought, we are facilitating a change process. So, ma'am, can you go to the next slide? The users, I think this, I had created a smart art, it got deleted. So the users, like, to summarize, this is especially useful for clarifying thought, clarifying your values, clarifying perspectives, to go deeper, to probe into this is what we had done in our example. We were probing into the situation. We were trying to uncover as many possibilities as possible, and then asking why. When if someone says maybe falling revenues are because of increasing wait times, I will ask why are those increasing wait times. If someone says the increasing wait times is because of the change in receptionist, then I will ask why did the reception was not why wasn't the receptionist trained, where was the lapse in our training system. So by this we come to the root of our root cause of our system, and thereby we prevent further damages also. So some examples of clarifying questions are, if someone says, this is because of increasing wait times, I would ask, why do you think that is? Have you noticed something about it? Have you especially noticed that patients are complaining this? And if someone says, our quality has gone down, then I would ask, what do you mean by this? So as to get more information. Then probably she would say, our OT wait times have increased. Our infection control, our septicemia rates have increased. So thereby you're going deeper and clarifying an issue. Some other questions you can ask is, could you put this another way? What do you think the main issue is? And can you expand the point further? Another use where we use the Socratic question is to challenge assumptions. For example, if I say, patients are losing trust because there are too many doctors available these days compared to earlier, then I would ask, why do you make this assumption? Then they would we are challenging them to come up with an alternative answer and to question the root of this assumption. And then I can also ask, is this always the case? There are instances where there are many surgeons, but then only one surgeon is very well trusted. So it is not, thereby I am showing them without my directly telling that there are other factors in place. Then they themselves will come with the answer ki it is maybe because of the communication skills of the surgeon. It is maybe because of the skill of the surgeon. We can also ask, how can you verify this assumption? Do you have any statistics to prove or disprove this assumption? Next, ma'am, going into probing questions. Probing, like similar to clarifying, we are going into another, we are asking deeper questions, and then, asking for evidence. Next, ma'am. Then there are another, we also are clarifying the consequences. Ma'am always used to ask, ki, if this happens, what could be the, what consequences would you see? If what are the good things about disclosing a medical error, or what are the consequences of not accepting a medical error, things like that. And then reasons and evidence. So how do you find out that if something is true? If I say, mothers are not willing to breastfeed just because mothers have become lazy these days, do I have evidence for it? Actually, evidence shows that mothers are more aware compared to previous generation about the benefits of breastfeeding, but then they are not able to achieve their goals because of lack of support. So by asking evidence, and for we challenge them, the other party to come out of their assumptions and actually search for evidence. Once they are not able to find the evidence, they will search for alternative answers. Once they start searching for alternative answers, then they will think, okay, so what is the support I need to give to mothers? And from there, the corrective action can start. And I think the most important is this last session key, where Socratic questioning, I feel, is most important in challenging viewpoints and in their perspectives. Because often when we talk about things in our medical dialogues with each other, we often talk about the doctor's perspective. And this is most of the things, like when we say that, patients are more demanding these days, they search for Google answers. And then ma'am was asking us, what about you? When you have to go to a certain place, do you not use Google? So we are then ma'am was then shifting our place from the medico to a consumer. And then that makes you see the viewpoint ki if I was a consumer, I myself would use Google and see. Maybe I shouldn't use the word consumer, but yeah, I hope you get the point. So when we ask questions in the right way, when we ask whose viewpoint does this represent, is it your viewpoint, or is it the patient's viewpoint, or is it the sister's viewpoint, then we can also ask what can be an alternative explanation, what can be another way to look at it. The other way to look at it is that, compared to the previous generation, our generation thinks better. We look for better alternatives, we have more choices, we are more well aware. That is actually a good thing. And then how would other groups of people respond? So how would if a certain issue has come up and the doctor believes that it is the patient's fault that the mistrust is increasing, but if you ask the patient what is their viewpoint, then a whole different story comes up. They see media images of blatant consumerism, and the very high bills on their wallet makes the entire game to shift from a beneficiary perspective to a consumer perspective. So questions like these sort of expand our thinking and shift our thought from our own viewpoint, and let us examine the viewpoints of others. And then finally, something called meta questioning, that is, if someone keeps on asking questions ki, what about this, what about my other colleagues, what about my when we are discussing about the importance of good communication, and there is one person who always just brings out questions just to disprove ki nothing can be changed, just to prove ki nothing can be changed, and he keeps on asking questions ki how will you manage very ignorant patients, how will you manage my colleagues, how will you manage the government? Then we can challenge that by asking questions again. So we can ask questions like, okay, what is the point of this question, or how can I benefit from this question, or can I ask if this question actually applies to our context? Can we benefit from this question, or can we focus on things which are in our hand? Next, ma'am. So some of the pitfalls, this method of teaching is actually pretty hard because it needs a lot of practice, a lot of time, and a lot of understanding of your audience. If the audience is not very open to talking, then you have this disadvantage of losing time, and you are spending so much time and energy trying to put out a case scenario, but then no one is answering, no one is thinking out of the box, no one is giving you answers which will help you build on the situation. If that is the case, you need to be ready with another mode of teaching. You need to think of an alternative. Another one more disadvantage is that though ultimately it is more effective in changing behavior, it takes a lot of time to get to the same answer. If I gave a didactic lecture, maybe 2-3 minutes would be enough. But if I have to conduct this discussion, I have to acknowledge their viewpoints and then build on it and then keep asking questions. It is going to take at least 15-20 minutes. And there's often a risk of vague, directionless questioning and and people building upon each other's answers and going on tangents. And ultimately, there might be a risk that you're losing sight of what you want to convey. And some other pitfalls is groupthink. Groupthink that means that if there is a group and some people are putting only some viewpoints just to agree with them, especially if these are more important in the hierarchy, or if they are more extroverts and they are more vocal about their opinions, other people will also just follow that opinion instead of giving their viewpoints. And similarly, like strong voices are easily more heard. And there's something called pimping. Pimping means you go on asking questions just to establish, this often happens during rounds. The senior keeps on asking the PG questions again and again and again, just to show ki you don't know, I know. There ultimately no one is learning anything, no one is changing anything, but question after question is just establishing is only to establish a hierarchy rather than to teach. So we should not fall into that trap. And then we need to make sure that there is a good closing. At the end of the discussion, there needs to be some takeaway points. There needs to be a plan of action. There needs to be a reflection of the different perspectives that have been presented. Yeah. I think I'll close here, ma'am. So, so throughout our this course, ma'am has been using these method a lot, and she has been presenting us with scenarios and then has been asking very good questions which challenge our assumptions and our perspectives and challenge us to open and think about other points of view. So I think that we need to learn.
So who is going to give feedback to Dr. Sneha? Okay, let Dr. Neha give it. Neha to Sneha. Huh? Yes, Dr. Neha, go ahead, please.
Yeah, excellent presentation, and she has given a little bit lengthy, but then she took all the points and she was very enthusiastic in explaining almost all the points in a very good manner, and so very nice presentation.
Thank you, ma'am.
Ma'am, it was a brief of the whole course in a way. I mean, how we have been doing this course. It was very nice, Dr. Sneha.
Thank you, ma'am.
Actually, the way you all are actually working hard on your presentations, you should get actually at least an hour to present your presentation. I wish we had that kind of time in the program. Then I think we could really cover everything in detail. But Dr. Sneha, I think you really did a lot of research. It was a very complete kind of a presentation on the topic. Socratic questioning, not very many people use, but that's an excellent way to engage adult audience. If you know how to ask pertinent questions, the whole program can be run on Socratic questioning. You don't require even a single slide.
Yeah.
But if you know like how to navigate your audience.
And I think it is one of those things into which you can easily integrate other things. Like you can easily integrate brainstorming, you can easily integrate storytelling, you can integrate
critical thinking, creative thinking.
Yeah.
It arouses a lot of introspection also.
Yeah.
Actually, Socratic thinking is about introspection.
Introspection only, yeah.
Without saying it, I'm making you introspect. And she could engage you all in her activity when she started her activity. You were all very keen in answering and, giving her.
But I think I made it more into a brainstorming rather than a Socratic questioning. I felt that I was not conducting it well.
because you went in depth. Otherwise, if you had just asked a couple of questions, probably it would have been a kind of a teaser that, okay, this is a pretty question. But that's okay. I think that's okay. So with this, we come to the end. I was hoping to take your feedback, but I don't want to hold you. It's already 11 o'clock. It wouldn't be fair on my part to ask you to stay back and give feedback. But what is the way out?
Ma'am,
Ma'am,
we'll share the
we-
feedback on.
Yeah.
We can give the feedback, ma'am, quick feedback. No problem, ma'am. If I'm ready to give, and if others are, maybe just one minute, we all can take.
Ma'am, 1 minute is a long time. It can be finished in 30 seconds. Also.
1 minute
30
or
seconds.
something like that. So,
I'll be more than happy if you're ready to give your feedback.
I mean, everybody says, then we go ahead.
Aditi seems
Sure,
very.
ma'am, sure.
Go ahead,
Who's
please.
starting?
So let Dr. Neha bell the cat. Payal is very tired, I can see. And I think we need to congratulate Payal. Payal, you have changed your job, I believe.
Yes,
Wonderful.
yes, ma'am. I'm just about to tell you that only. That I have changed and I've started my private practice, coming out from all the comfort zone. But I wanted to do what I really wanted to do it.
Wonderful. Congratulations.
Congratulations.
Yes,
All
ma'am.
the very best.
Congratulations and all the best.
Thank you, everybody.
You have heard my story, so now I'm sure you will be encouraged.
Yeah, yes. I was just about to tell you that time only that yes, I'm right now in that path only. But yes, we'll do it. Thank you for sharing.
Ma'am, what is the course? What is the use of a course doesn't leave you more motivated than you were?
Thank you. So go ahead, Dr. Neha. Yeah.
So I must say, ma'am, first of all, since I've been a clinician and been into patient safety and healthcare quality for more than 20 years, I was very keen to join this course by you. And I was, as you know, I was following for almost a year. And I must say that this course has, been beyond my expectations. And I mean, such a wonderful course, and it created a platform where all participants were engaged, and it's very engaging program. There are different pedagogies used, which we learned so much, and I'm sure I'm going to use all those nuances which I have learned into my further enhancement of my healthcare communication abilities, and also taking it further in training other people in the healthcare to make the system stronger. And thank you so much, ma'am. It's a wonderful program. And I wish it was not the last day today. We could have learned something more. So thank you so much, ma'am. Excellent program.
Thank you so much. Thank you for your kind words. Thank you. Yes. Who is
Yes,
ready?
ma'am.
Who is ready next? Okay.
Yeah, myself, Mamta. So the reason I have joined this program is I'm working in Apollo Med Skills, which is a learning center for the nurses in healthcare program below the pyramid of paramedics, nurses and all. So we have built one great program which is running through international level, which is fine. And in that program, there are 4 modules. The one of the most core module is the clinical communication. The reason I've landed up into this course program is to gain more knowledge about the clinical communication model, because we deal with national wide and international wide, and being into academic part, I myself should know the solutions for the problems which arise through the communication part. And I think I have landed up into a correct place where an experienced person who is genuine and who knows the genuine answers for the problems, not talking to monitoring terms or manipulating or tampering the situations, but dealing it in a fair situation, fair part is what I have learned through this program. And I'm very glad to be on this platform, on this program with such a great ladies and great people of top level. Yeah, this is wonderful experience and journey for me to be a part of this. Thank you, ma'am. hopefully I would look forward to connect you if there is anything other than this program. Yes, I would love to join again, all everyone. And thanks everyone to be coordinating and being graceful for me also in all my answers. And if anytime if I have hurted anyone by my words or anything, please forgive me. Thank you, Indu ma'am. Thank you so much.
Thank you, Mamta. Thank you. Thank you.
Ma'am?
Aditi wants to sleep. Aditi, you want to sleep? In case if you want to leave, please feel free. There's no problem. I understand. I mean, I'm sure you must have had a long day. Please feel free to leave if you want to go. I think Dr. Kundan wants to give his feedback. Go ahead, sir, please.
Yeah. So the master's program in healthcare communication organized by Indian Institute of Healthcare Communication. Dr. Indu designed this program very well. It was all the topics were excellent with comprehensive coverage of what a clinician or what a academic administrator, hospital administrator. In fact, every healthcare professional, what he faces day to day practice about the nuances of healthcare communication has been covered in excellent manner in this program. For me personally, as a practicing physician and a clinician, I got an opportunity to learn the other side of the patient side of any clinical treatment or stay or experience. I tried to fit in the patient's shoes, and then my perspective about about the patient's expectations, about their grievances, totally changed. So I think this has been a very positive program for me personally, and I look forward to attend such kind of programs in near future. Also, I would like to have train my in my capacity my hospital staff, my resident doctors, and have so that in day to day to put to use whatever I have learned in this program to put to use in practice. Thank you.
Thank you so much, sir. So kind of you for your words. I think Dr. Kundan has been one of the participants who actually pushed me to start this program. Although he could only join the 9th or 10th batch, but then he was one of those who actually insisted on, some program. And there we are. But Dr. Neha followed me up very rigorously for the last 1 year. Thank you. So I think Payal is ready with her feedback. Go ahead, Payal. Thank you.
Yes, sir. Yeah. So first of all, thank you so much, Indu ma'am, for introducing us with the term of communications in the healthcare. We are really fascinated to know, understanding about there is also such thing is existed and we have to learn about it. As we speak many a time, it is a skill, right? And you have introduced those skills to us in a very, very, very nice manner. It is not just the practical, but you have covered a lot of theoretical part also. Okay, so in the future also, like for the renewal of our knowledge, we definitely can go back and understand about this. The way you have made the presentation is so easy and so simple and so effective that anybody can understand how to go through it. Though it was a very difficult situations and the difficult topics you have covered, but you have covered in such a nice manner that it is very easy for us to understand. And we are really looking forward to do a lot many courses like this. And I think this has to be introduced at the UG and PG level as a compulsory course, the communications in the healthcare. So I think the government has to take it forward. And all thanks to you, the teachers like you, who introduce us to this. Thank you so much, Indra ma'am.
Thank you so much for your beautiful feedback. So friends, Payal got to me because her husband has attended my program at Reliance Hospital. So I did a 10 sessions program for Reliance Hospital, Bombay. So, I mean, at that moment, he had said, whenever you do next program, I would like my wife to do it. And the moment I informed him, I think Payal enrolled immediately for the program. So thank you so much for your feedback. Thank you. Thank you so much.
Thank you, ma'am. Thank you.
I think Dr. Manisha has raised her hand. After that, Dr. Amrit, is that okay?
Yes, ma'am.
Thank you. Yes, Dr. Manisha.
Yeah, Dr. Indu, first of all, I would like to thank you for mentoring us and for giving us such a wonderful gift of communication as a skill for healthcare. Since I've been working as a clinical person and then I shifted to administrative side of the healthcare, I had always talked about communication skills and soft skills among the clinicians and the administrative persons working in the healthcare sector. And there I see this opportunity coming from you. I was searching that where can I get a certification in communication skills regarding healthcare. So I'm very, very grateful that I enrolled in this program by IIHC, which is run by you. And no, I got to learn lots and lots. And today, as I complete this course of Master Trainers Program, and I really understand the role of effective communication in healthcare, and also how communication skills can help increase patient satisfaction, better treatment outcomes, improve doctor-patient relationships, decrease in medical errors and complications. I'm in a very, very big part, which every day, every hospital, every healthcare professional is trying to find answers to. And you have been a great teacher in every aspect, your patience, your calmness, your way to create curiosity, to find answers, to explore ourselves. That is commendable, ma'am. And really, really honored to learn from you. And it's an effective way of continuous quality improvement, I would say, for every healthcare sector. Every healthcare organization, communication is a way for continuous quality improvement. So what better to learn? Thank you, ma'am. And I think this association will not last here. We will continue this association and we'll keep learning from you. Thank you, ma'am, so much. Great.
Thank you so much. Thank you.
Ma'am, though there is not much left to be said because everybody has a lot of praises for the whole thing, and same here. And first of all, I mean, for me, the course has taught me much more than that was expected and promised. And you have been a fantastic teacher. You could keep us awake even till 11 after a hard day's, long day's work also. And amazing batchmates, truly amazing learning, brainstorming, everything was great. And not only about healthcare, I think the skills that we have learned here are going to help us in all aspects of life. And whenever you have an advanced course, just count me in. Thank you so much.
That's very encouraging. You're prompting me to have an advanced program after this. Thank you. Thank you. Yeah.
Ma'am, always.
Thank you so much. So I think Dr. Priya, you wish to share your feedback? Go ahead, please.
Ma'am, just 1 second. I have to thank Dr. Neha also because she only told me about you.
Oh, yes, I agree. She was the one who said that my friend also would like to join. So whenever you start, I will ask her to join. Thank you to Dr. Neha to have brought you in. And you brought in a lot of new perspectives and in-depth knowledge that you brought in. I think that would really help the youngsters to understand, deeper understanding of human behavior. Your contributions. Thank you.
Really, ma'am, relieved. I'm relieved that now Amrit says, okay, fine. I have not just got enrolled just like that. I'm really relieved to hear that.
Thank you.
Thank you so much. Yes, Dr. Priya, please go ahead. Yeah.
Ma'am, for me, it was a really great program with a lot of activities that we dealt and a lot of facts and details and numbers that you gave about each topic that you covered was a eye-opener. And for me, from the hospital, we have a lot of such trainings and such programs that are organized. I've been lucky to be part of quite a few of them. In fact, around 2 batches I've attended, and those programs have been very good. So when this program came up, I was wondering what new I would learn. But yes, I'm happy I did join because I got to learn, especially the role play part was a big eye-opener for me. Because that's what, I have dealt with a lot of such situations, but then when I actually dealt it and I realized there were so many flaws in what we do and how things could be handled better. And for me, the greatest takeaway was how to handle an aggressive patient, how to handle bad news, though I've been doing, not that I haven't done, but yes, now I know I could do it much, much, much better off. And then today's class was like, I must tell, it was a huge takeaway. So, ma'am, it was a great learning, great experience, and I have a lot of takeaways. And yes, I'll be looking forward to the advanced program if it is on. I would be one of the participants for sure. Thank you so much, ma'am. It was a lovely session and program, well designed and meticulously planned. Thank you so much. And I'm happy that I joined in.
Thank you so much, Dr. Priya. I think that was a huge compliment. I think all of you made it like this. I started, a program, but then participants kept refining it, and I think there we are. And I'm so happy that I'm able to meet some need of the healthcare, sector, because this one, part of communication or service was missing in the whole system. So I really wish that all of you take this forward and do trainings in your organization and make the name of IHC well known across. Now you are master trainer certified by IHC. So you please take it forward. Yes, Aditi, it's your turn now. Go ahead, please. I know you're
So
very
everything has already been said by everyone. So it was a nice course, ma'am. Thank you. I got to learn a lot of things, how to communicate with the patients with who comes every time very aggressive. And mainly I learned through the role plays we did in the course. So in that it was 515 plus 5 plus I will say. So it was a really nice experience getting to know more about communication and how to deal with the patients day to day environment.
Thank you so much. I think that was, and I believe, Aditi, you are probably experiencing a lot of, aggressive behavior from the patient party. Maybe the kind of geographical area you are catering there. At times we know there are areas where people are more.
Mainly the hospital is panel. We have a lot of panels in our hospital.
So I think you
CGH,
are, yeah. So you really
they're all
need.
government panels. So every patient comes with the aggressive mindset already.
So you have to really work on your team so that they learn how to handle those situations. I think that's the way I can.
Sometimes patient come with fine mind, but when they meet the reception staff, वो कुछ कह देते हैं उल्टी सी वो एक छोटी सी बात उन्हें बुरी लग जाती है, then their mood get disturbed and then they start shouting.
I agree. I agree. Yes, Dr. Sneha, I think you wish to share your feedback. Please go ahead. Yeah. Dr. Sneha, unmute your device.
Unmute.
I was wondering why I'm not able to take you in the spotlight.
Yeah, I'm sorry. So I think I'm going to echo everyone else. I wanted to say it was a lovely course, and apart from just the knowledge you gave, even what you are, like the person you are, also taught us a lot. And even everyone else in the in my colleagues here and my seniors here, I learned a lot from your perspectives and how you deal with it, because I only have a limited, very narrow experience, and coming from diverse backgrounds, the various scenarios that come up, because there'll be a mental image what might happen. So that is a learning, and it is very nice. I mean, this piece, the how medicalized our world has become, to bring back it to a human relationship. Ultimately, it's a relationship between two people. To bring back focus there, I think that's the perspective, that the change in mindset, I think, is the most important takeaway for me. And though I felt that it was always important, but then giving form and shape and words to that sentiment, I think makes it effective. And yeah, ma'am, I learned a lot about pedagogies also. I like teaching and I want to learn more about teaching. And so I learned a lot about how to teach effectively also. Yeah, it was wonderful, ma'am. Thank you so much.
Thank you, Sneha. So a lot of time I had a feeling probably you are not really getting benefited or you're not participating in the But I'm sure there must be some personal reason on your side that must be holding you
Yeah.
back. But from
Yes,
my
ma'am.
side, I always try to make sure that everybody joins in and everybody participates, and they open up.
I've been seeing the recorded sessions later. Because sometimes my childcare, I mean, if
Yeah.
I'm not able to hand over my child to someone, it was a problem. But then
Yeah, so honestly, I never doubted your dedication or your, sincerity, but I could see that probably you had certain concerns which were, holding you back from
Yeah.
participating fully. But
Yeah,
that's all
true,
I
true.
understand. We all have commitments and,
Yeah.
challenges in our life. Yeah. Thank you for being there.
Thank
Yeah. Yes,
Thank you.
Deepika, go ahead, please. Yeah.
Yeah, I wanted to keep it last. So firstly, thanks a lot, ma'am, because you gave me a very good opportunity for the second time. And thank you for that, because I think I would have regretted the most if I have not completed this course properly. The best or the key takeaways that I had in this course were the different concepts that you brought in, the pedagogies that you taught us, because keeping it alive and engaging is definitely challenging on an online session. So the engagement that you had with each one of us, because you connected with each one of us on a personal ground, and you acknowledged our feedback, and you ensure that you took our feedback so that you can incorporate that in your model. So that was really welcoming, and that gave us, each one of us, little bit more motivation, so that we wanted to voice out our opinions, no matter what, that we were running out of time, like even for today. So that was really nice. And also the other part was, as Dr. Sneha said, you as a personality, I think with whatever other challenging tasks that you're doing, you also gave us a lot of moral lessons in this 10 weeks of session, like being on time, and then how you can multitask a lot of activities. And apart from that, as everyone knows, communication is something cannot be learned just by attending one particular course or something. But I think each one of our lives could be easily differentiated between before the master trainer class and after master trainer class. I think that's the best part of because right now, even when I take a decision or when I interact with the patient, automatically my mind kind of clicks in with our examples, with the other perspective of what the other colleagues had shared. So I think that's the most best part of this session, and I think you have achieved that in each one of us, and you have instilled that thought in us. So thank you so much, and thanks a lot the other participants, because each one of them have made it very, very interactive. And only challenge that I had was I was not able to connect with the Hindi part of the sessions. So I tried my level best, and I regretted that I should have done my spoken Hindi. But anyways, otherwise everything was really great, and thanks a lot for this. And as everyone said, I'm in for the advanced course, so please let me know if that comes up. Thank you, ma'am.
Thank you so much. I think, Deepika, that was a huge compliment. When you said that when you are in a situation and you immediately think that, how as a group we would have taken a decision in that, I think that's a big thing. If you can bring that in your way of handling situation, I think that's a beautiful takeaway. Thank you for that feedback. Thank you. Thank you so much. Yeah, Santoshi, go ahead, please.
Yeah, ma'am. Ma'am, first of all, thank you so much, especially for developing this concept of healthcare communication, and especially a master training program on it. And the way the whole program you have planned, you have designed, especially the presentation and the way to deliver it over the period of 10 weeks, and that too online, it is very, very good. Like online doing it, involving, having the whole participant involvement, as well as, and this is a first ever concept in India, if I'll say, and IAHC. So I personally, I liked a lot, being from a trainer background, and all the pedagogies, I have seen it, like we have demonstrated, and you have demonstrated all the pedagogies. And like today, the Socratic questions, that was really new to me, though we have used that concept on and off, but like the terminology, if I'll say, that was completely a newer concept for me, and I would like to incorporate that in my training programs when I'm doing it. And secondly, ma'am, as a facilitator, you are excellent. And because if you see, we have a diverse group of audience here, like all from a different background, clinicians now into administration, and many senior clinician here like Dr. Neha, Dr. Manisha, Amrit ma'am, you, Dr. Kundan, Dr. Priya. So like what I feel like, having a diverse group and youngsters like us, and maintaining the whole respect, handling the difficult question, you know when to stop them, you know when to start. So as a facilitator and handling an adult audience is very difficult. So I really appreciate and I learned that from you, like how we need to do it. So, and as everyone said that advanced program, definitely ma'am, but in between also, if I get a chance to conduct like any of the sessions that we have learned so far, in especially I belong to an out of hospital setup, but via this program I came to know about the problems which inside hospital team is facing with the patients. So that is a newer understanding to me. So, but yes, at the end, I would also be like to part of advanced program in future if you are coming up. So thank you so much, ma'am. And all the best for your future endeavors, and especially the tie-ups that you are having with the organizations. So all the best, ma'am, for the same.
Thank you so much. Thank you, Santoshi.
Thank you, ma'am.
I would again say it's a huge compliment because all of you are experts in your field. And if you feel that I could do some value addition to your work, I really feel humbled with your compliments, and I feel encouraged that I have to continue this. So every time I end a program, I think, okay, let me give it a break. But by then already 4 or 5 people have inquired, and when are you doing the next one? When are you doing the next one? And then I think, no, I can't stop. It has to go on and on. Trust me, if I show you my calendar, my whole calendar is red. So finding time for master trainer program is a very difficult thing right now for me, because if I'm working whole day, then 8 o'clock at night, it becomes very much, difficult for me to do the training. But can you believe that already I have to decide the date? I have decided the date for the next batch. And on 29th of July, I'm starting the next batch, that is batch 11. So, and already 3-4 people have registered, they've made the payment, because they think that if they will not do it now, then maybe they'll miss the bus. But that's how the things are, moving. But I think this is the encouragement coming from all of you, the kind of the feedback that you give me, and the participation that all of you have done. See, it's past 11 o'clock. You are tired, I can see that, but you don't want to, miss the bus, and you want to be with us, you want to participate. I think that's what motivates me, and I feel I'm doing a, maybe it's a drop in the ocean of, healthcare, but maybe tomorrow we all make a change wherever you are, whatever you do. If you can integrate these virtues that we have discussed here, I'll be more than happy. I'll be more than happy to hear that you have been able to bring some change in your system. So,
ma'am, you believe in and practice what you are teaching. That is the best part.
Yes, I think that's what keeps me, moving. And I believe you cannot fake. You cannot fake. You can maybe fake once in a while, but that cannot be the way of your life. And ultimately, people will get to know about your real self. And I don't believe in, having that double kind of an image. रात को उठा के पूछ लो, दिन में पूछ लो, the answer will be same. That's what I believe in. That's what I believe in. And I really recommend that to everybody, because ultimately we have to reply or answer 2 people in the world. One is self and second is God. Rest others you can all fool if you want, the way you want. So thank you all. It's time to bid goodbye, but we'll stay in touch. I will not dismantle the group. We will keep the group there, because once in a while you can all put your message or whatever thoughts you have. I've shared feedback form and also a post-training assessment. And I want you to complete both the forms tomorrow at your convenience. Dr. Aparna, if you are there, we haven't heard from you. I mean, there's a slight feeling in me that your participation was not, really, maybe there must be definitely some genuine reasons at your end. Maybe your OPD timings somehow are in clash with the sessions that we are holding. We got to see less of you. I wish you were there. We could hear more from you. Dr. Aparna, are you there? I can see you're logged in. Okay, that's okay. I think I'll close it here. I'll not hold you back further. Thank you so much. Good night.
Okay, thank you, ma'am. Yeah.
Thank
night.
you, ma'am.
Thank you, ma'am.
you.
Bye,
Good
everyone.
night.
Bye,
Good
everyone.
night.
All the
Bye,
very
bye.
best
Thank
for
you, ma'am.
everyone.
Thank you.
Bye, everyone.
Thank you,
Bye.
ma'am. Bye, everyone. Thank you.
Bye, everyone. Bye.
Night all.
Bye.